हाँ जी, ये चल रही है ना, में पार्टिसिपेंट्स लिंक ट्रांसफर हो जाएगा व्हाट्सएप की नहीं खुलता था ठीक है क्रोम के व्हाट्सएप कितना सी पर वो भी चलिया नहीं, वो कुछ और डिमांड कर रहे पता नहीं। अच्छा फिर हाँ जिसका ये स्कैन किमें करेंगे ये भी नहीं होगा कोई स्कैन ਦਾ ਹੁੰਦਾ ऑप्शन ਇਹਦੇ ਤੋਂ ਉਹ ਕੈਮਰੇ हाँ ना पे जो ठीक है यूज पिन कर देते हैं पिन कर स्कैन सब चीज हो रही है व्हाट्सएप पे चलता कैसे अपना अच्छा चल मैंने स्कैन कर दिखा था सर मैंने इतना लॉगिन ये मुस्कान यार स्कैन कितों सीधा कितना कोई ऑप्शन नहीं देती आई सी हाँ जी बंदा से मीठी पहला ली मीटिंग पासवर्ड हाँ बाद 1 2 3 4 5 6 रन करके बह जाएंगे तो ना फायदा मिलेगा दूसरा टॉपिक देख लेना मीटिंग बाद में बंद खत्म हो गया नीचे चल जाएगा हाँ ऐसा कुछ पता है अभी नहीं चल रहा सेशन कर रहे फुल है ना भी 10 पार्टिसिपेंट्स है, पहला टॉपिक है मेरा।
सर आप आ गए अच्छा खोलिए
सेटिंग्स
सेटिंग्स से जाके अपना पे देखिए सर स्कैन आप कोड या तो किसी दूसरे को चलाना है दूसरे फोन से तो वो स्कैन करूंगा एक कोड तो कंप्यूटर करना उसको स्कैन कर दूंगा तो जितना स्कैन करूंगा तो
हेलो
वॉल्यूम बढ़ाएं सर
What? Pardon? No, it's just like.
गुड मॉर्निंग सर।
तेरा नंबर, हाँ गुड मॉर्निंग, तेरा नंबर मैंने दिया उसको अभी।
ये सर हर साल जो है वो पता नहीं क्या नंबर नोट कर रखा है उसको।
हाँ।
पिछले 10 साल से हर बार कहते हैं सर आपका नंबर सही नहीं है, जबकि मेरा नंबर ये है। और इतनी बार ही मैंने इलेक्शन कमीशन को लिख दिया, मैं इस पे वोट करता हूँ, यही मेरा ऑफिशियल नंबर है, पर उनके रिकॉर्ड में पता नहीं क्या नंबर लिख रखा उन्होंने।
Might be something, it happens.
मुझे तो अभी पता लगा क्या टॉपिक है। आप कौन चेयरपर्सन है, सॉरी कौन स्पीकर है और क्या
टॉपिक मुझे पता है, स्पीकर भी पता है मुझे। टॉपिक है न्यू इरा ऑफ साइकेडेलिक hallucination associated treatment in psychiatry.
न्यू इरा ऑफ
Psychedelic drugs,
साइकेडेलिक ड्रग्स। हाँ,
treatments in psychiatry.
ट्रीटमेंट इन साइकेट्री। ठीक है सर, आप स्पीकर को इंट्रोड्यूस करा देना, बोल देना।
मैं कर दूंगा।
ठीक है,
थोड़ा टॉपिक इंट्रोडक्शन दे करके।
ठीक है, ठीक है, कर देना। राइट सर,
मेरे पास अभी आया नहीं इंट्रोडक्शन।
ठीक है, जब आ जाएगा तो आप कर।
बाहर कोई ये वही तो नहीं जो कोटा में है लड़का, जसर अब्दुल जब्बार?
अब्दुल जब्बार तो कोई नहीं है कोटा में।
अच्छा, कोई नहीं है। अच्छा अच्छा, कोटा में इसको हम इस पर करेंगे, ये दो स्पीकर है ना। बंद करें इसको, कर दो बंद कर।
हेलो
इंफॉर्मेशन
हेलो हेलो पुरुषोत्तम सर।
यस सर।
सर आप एक ही डिवाइस को लॉगिन कीजिए, नहीं तो इको होगा।
मैं आई अंडरस्टैंड इट, आई एम जस्ट लीविंग इट द अदर
ओके
डिवाइस।
सर, ओके सर।
हो गया, इसको लीव कर दो। कैसे लेंगे? ये तो इनको वैसे इस पर जाने के लिए लिंक है। मैंने उसको बोला था कि मेरे कवर जो है बायोडाटा भेज दो, तो नहीं तो सेम सेम उससे बात ही कर। हाँ मुस्कान, वो जो है ना स्पीकर जो है उनके बारे में इंट्रोडक्शन पढ़ देते ना।
हाँ हाँ, आपको अगर मैं प्रेजेंट करूँगी तो आपको भी दिखेगा, तो मैं आपको
अच्छा 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 अच्छा, आप
टीवी भेज
प्रेजेंट
देती हूँ, मैं आपको टीवी का फोटो भेजूंगी।
टीवी का फोटो, ठीक है, तो वो इसमें डिस्टर्बेंस
मैं
नहीं
आपको
होगा।
व्हाट्सएप
व्हाट्सएप पर ठीक
तो
है,
आपको
बिल्कुल ठीक है,
करने के लिए
ओके। टीवी का फोटो भेज इसको हम समझना।
सर क्या दे रही है अब?
Should we start, Dr. Shekhawat,
Yes, please.
or should we wait for the speakers to come?
Oh, speaker should be in the time.
I'm not able to see the speakers.
Ask the host.
Yes. We'll just ask. Probably ये मैसेज जो हम बात कर रहे हैं ना, ये होस्ट के पास चली गया है.
हेलो.
मुस्कान स्पीकर्स आए हैं ना, अभी नहीं आए मेरे
हाँ
पास.
हाँ हाँ. स्पीकर आ चुके हैं. 2 मिनट सेशन है. 2 मिनट just 2 minutes.
Okay, ठीक है. Then inform us and we will start.
No, I will.
You invite me
The
for the
mic.
introduction of the topic and introduction of the speakers
I'll
and
invite
Dr.
you as chairperson, and then you can invite the speaker.
Dr. Shekhawat has also joined. That's a good thing.
Yes, yeah.
Okay.
Okay.
उनके बारे में ढीला है. Session.
Hello, doctor, can you hear me?
Yes.
Yes, please.
Can you hear me?
Yes, madam.
Okay. So we'd like to start with a session on symposium, the new era of psychedelic hallucinogen associated treatments in psychiatry. Will it be a game changer? So for chairperson, we have Dr. Bharat Singh Shekhawat and Dr. Purushottam Das Garg joining us online. So I would like you to invite our speakers on the dais, please.
Dr. Garg,
Yes.
please invite the speaker.
Yes. She has invited. The speakers are invited for presentation of their topics. The topic is about the psychedelic assisted treatments in psychiatry. Can it be a game changer? As all of you know, that there are certain psychiatric disorders like depressive disorder, anxiety disorder, and PTSD. These disorders, we are not able to treat them fully well with the traditional antidepressant and anti-anxiety drugs. And it has been seen since 1960s that the drugs like psilocybin, LSD, mescaline, MDMA, and ketamine, and ayahuasca. These are the hallucinogen drugs which are helpful in bringing about some change in the, condition of the patient. So probably they act by act of neuroplasticity of the brain, and some new connections are developed in the brain as a result of the use of these drugs. But the drugs have their own, problems, that they are all drugs of abuse and they can be misused by the society. So with this brief introduction, I will request I will request Dr. Shekhawat rather. Will you, sir, introduce the speakers?
Sir, I don't have the
Okay.
biodata of the speaker.
I'll just speak the name of the introduction speakers. They are Dr. Jassar Abdul Jabbar. He is a consultant psychiatrist at General Hospital Trivandrum. And we have another speaker is Dr. Arun Ayappan. He's a consultant psychiatrist at Government Mental Health Center, Trivandrum. So both are, they seem to be very young people, dynamic people. So I think they will bring justice to their topic, an interesting topic of psychedelics. I have also read about psychedelic assisted psychotherapy or pharmacotherapy. Ketamine especially, we have been listening within the last 2-3 years before the COVID. So I request Dr. Abdul Jabbar, kindly start with your presentation. Dr. Jabbar, sir.
Thank you, sir, for the kind introductory words.
Just ask it.
Am I audible, sir?
Yes, please go
Yes,
ahead.
please.
Okay, thank you, sir. So thank you for that kind words of introduction, calling us the young dynamic psychiatrist. It is after a gap of 2 years that I'm able to present a second topic. And we are all happy that at least it was my dream to come here as an offline presentation, because since we have all been fed up of being with online presentations, and it's a happy moment for all of us. Thank you. So today's topic, maybe much of our faculty might not be so much familiar, but I would like to give some words, and it's mainly an introductory topic so that we can sensitize our psychiatrists to the future prospects of such possible treatments. And the topic is now the new era of psychedelics or hallucinogen associated treatments in psychiatry. Will it be a game changer? So the reason for selecting such a topic is, as we all know, in psychiatry, many people tend to get desperate on the fact that some of the disorders are treatment resistant, and to understand the complexities of mind, it is very difficult to have researches on that, and we have a lot of limitations on such topics. So it's a deeper inquiry to understand that whether you have such a possible outcome, whether you get a possible good outcome from psychedelic associated treatments. So this is by Vladimir Horky. That means everyone, whatever you construct in your mind is a lingering self-created thought. There is always a paradise beyond. This is what sometimes some people might be familiar with such thoughts, like people who are deep meditators, maybe Buddha, maybe Zen, all these form of thoughts, they might have experienced a paradise beyond, which we usually call self-actualization, enlightenment, or self-realization, such terms. So we are, there is such a possibility for psychedelics, which I'll be explaining. Now, the outline of the presentation is, there is an introduction, history and early research on this topic, the typical psychedelic effects, the early therapies associated with this, the pharmacology and adverse reactions, and the neurobiology. And the rest of the presentation will be done by my co-speaker, Dr. Arun Ayappan, where he will be explaining the psychedelic assisted psychotherapy, current evidences, and future prospects. Now, what does the word psychedelic mean? It means simply, in Greek, it simply means mind manifesting. This was a word coined by a psychiatrist named Humphrey Osmond during a written correspondence with Aldous Huxley. They had a correspondence on psychedelics, and subsequently this name was, he felt it was more suited to this. Now, other terms associated with psychedelics are mainly, yes, I told you, as I told everyone know, it is hallucinogen. If you go to the standard textbooks like comprehensive textbook of psychiatry, they'll be mostly telling hallucinogen assisted psychotherapy. But in a wider circle who are more passionate about this research, they'll be using the term psychedelics. Now, psychotomimetics means there are other terms for this. Psychotomimetics, psychotogenics, which means to mimic psychosis and to induce a psychosis respectively. Initially, during the 50s, these drugs were indeed used to understand schizophrenia and psychosis as a model, so that they could induce psychosis and understand more the complexities of these disorders, which we are yet to recognize now also. Now, psycholytics is another term to loosen the mind. I'll be coming with the psycholytic term later. Then entheogens means to generate the divine within. Okay. So essentially, these are a group of compounds that produce various psychological effects characterized by altered states of perception, thoughts, feelings, and consciousness. Mainly, altered states of consciousness is what the researchers are mainly interested in, which might create permanent changes in your brain. Now, the main molecules are, as everyone knows, as our chair introduced, these are LSD, psilocybin, mescaline, dimethyltryptamine, which comes under ayahuasca. It's a component of ayahuasca. These are considered to be the classical psychedelic molecules. Whereas literature also includes MDMA, which is also called as ecstasy, and ketamine as molecules, even though their mechanism of action is found to be slightly different. The other molecules which are mentioned here is they are obtained from some plants with no significant clinical studies are not being conducted on such molecules. The main studies are being conducted on these molecules, and ketamine, we won't be coming into the depth of ketamine in this introduction, because as everyone knows, it's a Schedule 3 drug and everyone is now using it. So we will not be coming into the evidence of much of ketamine. We'll be discussing the other molecules. So these have been employed as adjuncts to psychotherapy for a wide range of psychological problems, from anxiety, affective disorders, and addiction. These are the three main areas where the researchers are conducted. But when you go to 1950s, which I'll be coming later, you'll see in a wide array of topics, it was actually being, the researchers were being conducted. Now, it has a wide variety of psychopharmacological actions. Now, this is something which we have to understand, which differentiates it from the usual molecules, that what the psychedelic researchers claim. And there you have a limitation in doing researches due to this kind of action of these molecules. It is a combination of psychological, biological, environmental, sociological, and personal aspects of the person, which we commonly call set and setting. There is something called set and setting. This is a very important term used in psychedelics. Set means the inner state or the psychological and the biological state of the person, and setting means the environment. So to administer such molecules, the environment is very important. The stimulations, the perceptions that you're getting at that point of time is very important, which is thought to create permanent changes in your brain and create lifelong, long-lasting effects for at least a period of time, or sometimes even lifelong lasting effects, where you might have some mystical and enlightened experiences. So this account for the totality of the experience. Now, in history, if you check, you have seen that humans have used psychedelic drugs for spiritual and religious purposes for centuries. In Europe, there were rudimentary physicians were using it, so like molecules such as belladonna, henbane, and mandrake root to treat a range of mental and physical disorders. It was in the modern era, it was in 1890s, a German pharmacologist conducted a scientific analysis on peyote cactus, from which the molecule mescaline is extracted. So he provided one of the earliest classifications of the psychoactive drug properties, like euphorians, inebriants. Inebriants was for alcohol, euphorians was for opioids, and fantastica was the word which he used for the psychedelic mode of actions, which were something different. The experiences were something different from the two other molecules. Now, it was explored by Mitchell and Havelock in their two papers, The Phenomena of Mescal Intoxication and Mescal, a New artificial paradise. Now in 1897, the mescaline was finally isolated from peyote cactus by a German pharmacologist called Hefter. Now in 1912, it was for the first time, German pharmaceutical company, Merck Synthesis, they took a patent and they extracted 3,4-methylene dioxymethamphetamine, which is called MDMA, or which we call as ecstasy, which is considered to be a drug of abuse. And but even though they have extracted it, the researchers, or its use as a molecule for psychiatric purposes, maybe it was used only after the mid-50s. And now in 1927, Berninger, who was experimenting with synthetic mescaline, proposes one of the earliest models of psychosis based on the psychedelic experience. And there comes the psychosis experiments. Now, here is a very important person to whom this psychedelic community is very much indebted to, the researchers. Albert Hofmann was one of the person, everyone must be familiar with his word, with his name. He was the person who synthesized LSD 25. It was called 25 LSD 25 when it was synthesized in 1938 in the process of attempt to develop a respiratory stimulant while working with Sandoz Laboratory. So indeed, he developed it and he found that the molecule was not useful for the intended purpose. So he kept the molecule aside. And the other thing was mescaline experiments were continued by Taylor Stockings for developing a biological theory of schizophrenia. And the breakthrough for these psychedelic experiences came in 1943 when Albert Hofmann accidentally ingested LSD. It was the first unintentional trip. Usually LSD trips are called as acid trips by the people who abuse it or who consume it. So he had his first unintentional trip without expecting anything. He took a microgram dose of this, and he had a mystic psychedelic experiences. Now, Hoffman's colleague Stroll was the person who first published the academic description of the Mendel effect of LSD on humans. Now, the Sandoz Laboratory, they makes LSD available to all psychiatrists in the world under the name Delsit in the 1950s. And in 1949, a Swiss psychiatrist gives it to a wide range of patients, even to patients with schizophrenia, proposing that it even has antidepressant effects, which needs to be clarified later. Now, it was Rinkel who proposed that LSD interferes with other forms of catecholamines like adrenaline and noradrenaline to produce psychosis. And you must even be knowing that LSD research and mescaline research all contributed even to the development of phenothiazines in chlorpromazine, which was our breakthrough in antipsychotic, which was one of the landmarks in antipsychotic treatments. Now, Friedman is one of the first scientists who proposed the link between LSD and serotonin, which is now even the standard definition for psychedelics, the action of psychedelics, that is their relationship with serotonin. And three scientists developed the transmethylation hypothesis for schizophrenia, which means that after a stress process, there is a biological change and there is a transmethylation hypothesis. As a result of that, he proposed the transmethylation hypothesis. International research continued in various parts of the world with this. And Sanderson is another scientist. He proposed the first built facility for LSD therapy, and he speaks at the American Psychiatric Association describing his psycholytic model. Psycholytic model means it is more of a small dosage, use of small dosages for treatment of various psychiatric disorders. And in 1957, it was Gordon Wasson who publishes a life article on magic mushrooms, from which psilocybin was extracted. And in 1959, the same Albert Hofmann isolates the molecule psilocybin from mushrooms, which creates the mystical hallucinogen experiences. In 1959, it was Osmond and Hofer used LSD on patients with alcohol dependence, and they found out some results with supportive psychotherapy. They describe abstinence rates up to 90%, even though it was not for a long duration described. Now, in history, you can see that classically, LSD experimentations continued during the 1960s, and you can find out that they were used for a variety of conditions like neurosis, depression, social anxiety in autism, female frigidity, and it was even used in homosexuality, which was considered to be a disorder at that point of time. And LSD was experimented in children with autism. So they reported some improved in speech, the greater emotional responsiveness, increased positive mood, smiling, laughter, and repetitive stereotypic moments were found to be reduced, decreased OC behaviors also. Now, next comes the era where slowly the ban starts to come in. LSD-induced psychosis case reports start to appear as there is a surge in recreational users in 1960s in the counterculture movement. LSD was a wide drug of abuse at those periods where the counterculture movement in 1960s, popularly known as the hippie movement, where the people started consuming these in mass amounts, and they started having raving parties and celebrations. So their LSD-induced psychosis reports started to appear. But in spite of that, there were some 2,000 papers between 1950 to 1966. It sounds astonishing, and very few of us seem to be aware of that. Such a large amount of research was conducted on those days on these psychedelic molecules. When prescribed judiciously in the clinical setting, they found that this LSD was indeed safe and effective. Now, a review of studies from 1915s that included 5,000 subjects and 25,000 drug sessions find rates of psychosis of only about 0.2% and suicide of only about 0.04%. So it just suggests that if used under safe settings with experienced hands, this might be of use, and adverse effects might be not as assumed. Now, there was a large meta-analysis at the end of 1960s with 4,000 patients and 50,000 sessions. But here you can find 2 completed suicides and 37 patients with a prolonged psychosis. So we have to be always be aware of this, and where the right person was to be found out for the treatment is also need to be investigated. Now, by 1966, LSD was finally banned, and it was widely used for this recreational purposes. Now, there are some reports which suggest chromosomal damage with LSD, which was contested later in some other reports in 1980s. By 1970, the US passes under Richard Nixon government. It was actually President Richard Nixon, which was so keen on passing this act, included LSD as a Schedule 1 substance. By 1985, MDMA was also included as a Schedule 1 substance. And so the research by 1970s, the research for this molecules came to almost to a complete halt. So by that time, there were a lot of people who were still enthusiastic for these researchers. In 1988, the Multidisciplinary Association for Psychedelic Studies was formed for conducting further studies on this. 1988, 5-HT2 receptor was identified as a target to LSD finally in the neurobiological studies. Now, the resurrection of these studies came back in 2006 when the Roland Griffiths, a very highly respected psychopharmacologist and a researcher, came out with a landmark paper. It was actually not on any psychiatric disorders in particular, but persons who were given this can occasion mystic experience, and they have substantial and sustained personal meaning and spiritual significance, which marked the reception of these hallucinogen assisted psychotherapy researchers. Now, what are the classical typical effects, hallucinogenic effects of such molecules? The classical hallucinogen effects is indeed, they have enhanced sociality. When people, you say that they tend to have more, they become more sociable, they become more happy, they have a feeling of closeness to others, they have an openness to the new experiences, then they have emotional empathy towards others, trust, feelings of bliss. These are subjective mystical questionnaire experiences that has been reported in psychedelic effects. Now, audiovisual synesthesia is one thing which has been frequently reported. Derealization, depersonalization experience, profound mystical experience characterized by a feeling of boundlessness, where you say that there is a sort of ego dissolution, the ego boundaries are being dissolved, and you have a feeling of oneness with the world, and enhance introspection. Then there are some effects which can cause, as I told you, acid trips can also be some trips like bad trips, which you might have encountered in your clinical practice. And that is like sort of anxiety, fear, panic, dysphoria, paranoid and auditory hallucinations might all be present in this. So in the sessions where the therapies are being occurred, the side effects are always being affected. If the right set and the setting is not there, there are high chances, and if the doses are a bit high for that person, there are high chances that this can go into a bad trip, and this can cause uneasiness for the person. And since this has a long onset of action also, LSD might even have an action of about 12 hours. So the bad trip can go for a long time. Now for MDMA, it is also being called as entactogen, which means touching, within, or empathogen. If classical psychedelics, the mystical experiences and ego boundary dissolutions are more being reported, in MDMA, it is mostly called. Okay, I'll continue. Yeah. So it is mostly associated with, it is mostly considered as an empathogen, where it has empathy and feelings of closeness is more being reported by people who use or abuse MDMA. Euphoria, anxiolysis, sense of inner peace, and psychostimulant, but no much hallucinations has been reported with MDMA compared to the classical hallucinogens, which means that the mechanism of action is a bit different. Now, there were two forms of early therapies in psychedelic therapies. That is mainly psychedelic, the high doses therapy, like psychedelic therapies, which we call classical psychedelic therapies. In LSD, it was the main studies were conducted in LSD, which will have about 200 to 800 micrograms of psychedelic sessions. It's a single session, induce an overwhelming conversion like peak experience, bringing a new level of awareness and self-knowledge, and thus a self-actualization process. Now, there are pre-preparatory sessions and follow-up integration sessions. In the initial part, even the therapist used to take the drug and be on with the person so that they could, but now things have been changing. And the set and setting is very important in such sessions, like music sessions, some important stimulation sessions and all are an important part of the therapy. And the follow-up integration sessions are very important in such therapies, because the change that the person needs to get from these sessions are further discussed in the follow-up and integration sessions. They were found beneficial in terminal cancer patients, in alcohol use disorders, narcotic use disorders, neurosis, and reported transient analgesic effects. Now, the psycholytic means it's a low dose therapy. It is introduced by Sanderson, as explained earlier. It was giving low doses of LSD, psilocybin in low doses, and it was used an adjunct to psychoanalytically oriented psychotherapies, which were more prominent on those days. Now, they facilitate regression and the recollection of emotionally loaded repressed memories, causes transference reaction, and some review studies reported improvement in anxiety, depression, personality disorders, sexual dysfunction, and OCD. Now, the limitations of such studies on those days were they were methodologically flawed, no control groups, because it is very difficult to get controlled groups, because considering the intense experiences with these drugs, and the vague criteria for the therapeutic outcome, no firm conclusions on long-term efficacy, and not clear whether the drug was a drug or the therapeutic engagement alone that produced the reported financial benefits. Now, these are the mainly the pharmacology effects. I'll be coming to that. Everyone, you can check for the classical psychedelics. The main actions are through the 5-HT2A agonism receptors. In LSD, it has 5-HT2A partial agonism. Ayahuasca, it is the dimethyltryptamine, which is the molecule in ayahuasca, which is responsible for the psychedelic action. This also has 5-HT2A agonism. And in MDMA, you will find that it is mostly associated with the transporters like norepinephrine transporter, serotonin transporter, and dopamine transporter. Then it is associated with the intracellular sequestration of MDMA and reuptake inhibitors. Apart from that, various receptors have been proposed, like mixed D agonism, antagonism in LSD, and in MDMA, there is vesicular monoamine transport 2 inhibition action, which may account for some of the adverse reactions like bruxism. Okay. Now, in the pharmacokinetics, it is mainly the glucuronation of metabolites. It's the main mode of the metabolism in the pharmacokinetics for most of the molecules. And in ayahuasca, it is the MAO substrates like beta-carbolin harmine and MAO substrate leads to the pharmacokinetics. The MAO inhibitors leads to dimethyltryptamine being orally active. And in MDMA, it is the zero order kinetics, and it is usually by the CYP2D6 pathway and by the catecholamine O-methyl transferase pathway, and sulfuration, glucuronation of metabolites subsequently occurs. Now, these are the common adverse reactions. Mainly, you can see any cases, the action of the drug is being determined by whether the patient has mydriasis, mild hypertension, tachycardia, dizziness, nausea, anxiety. These are some of the actions which has been reported. And if you look at MDMA specifically, you can see that there is something called bruxism, fatigue, xerostomia and all. Bruxism, as I told, maybe the VMAT2 inhibitor pathway, the pathway might be responsible for the specific bruxism effect. Now, the neuroanatomical effects in psilocybin, it reduces the negative effect and amygdala response to the emotional phases, enduring changes in resting state functional connectivity, reducing the activity in the default mode network, which is considered to be the pathway for the mind wandering pathway in meditation and all. The default mode pathway is mostly being checked. So reduced activity in the default mode pathway is one of the mechanisms being proposed as for the decrease in mind wandering and the subsequent stresses and the subsequent relaxation or the responses in various conditions which causes an increase in default mode pathway like OCD, addictions, anxiety or depression. Now the changes in standard plasticity has been reported. Now in LSD, it increases the plasma concentrations of cortisol, prolactin, oxytocin and epinephrine, increases the global functional connectivity between the various pathways and reduces the left amygdala, which is commonly known to stimulate the fear responses and the emotional responses, and right medial prefrontal cortex reactivity to fearful places. It also increases the functional thalamic connectivity with the insula and right fusiform gyrus, which is thought to be the reason behind the mystical and the psychedelic or self-actualizing experiences, enlightenment experiences and all, the ego boundary dissolution and all are proposed to be that. Now, it also decreases the default mode integrity. Now, in ayahuasca, it has the 5-hydroxy dimethyltryptamine, hypothesis to be responsible for dreams, creativity, and mystical experiences. It is involved in fear extinction also, maybe on the action of amygdala. And antidepressant effects with cellular and behavioral responses are similar to ketamine also. Now in MDMA, there is a decreased neural activation of the left amygdala in response to the angry versus neutral phases. So they perceive your faces as more friendly and more lovely. A lower activation of left anterior temporal lobe and greater activation of superior frontal gyrus, decreased resting state functional connectivity between the prefrontal cortex and hippocampus, and increased resting state functional connectivity between the hippocampus and amygdala, which might be the responsible for the actions in the post-traumatic. The trauma-related memories might be acting by the prefrontal cortex and hippocampus and by the hippocampus and amygdala mechanisms. So all classical hallucinogens in turn display high affinity for 5-HT2 receptors. They interact with some degree to 5-HT1, 5-HT4, 5, 6, and 7 receptors. In addition, LSD shows some high intrinsic activity at dopamine 2 receptors and alpha adrenergic receptors also. Now, ketamine, just a mention of ketamine, we are not discussing in detail. Everyone knows that it blocks the NMDA receptor at the PCP binding site at the receptor's inotropic channel. Now, this is the neurobiology of the classical psychedelic molecules. Here you can see that in the glutamatergic pyramidal neurons in the deep cortical layer, there are 5-HT2 receptors on which the classical psychedelic molecules act. And they also act on the 5-HT2A receptor molecules on the pyramidal neurons in the cortical layer 5. So this is considered to cause an increased glutamate release, which in turn causes NMDA and AMPA activation, which leads to subsequent brain-derived neurotropic factor expression, which is considered to be the changes causing or the plastic changes causing is proposed in such a mechanism. Now, this is just about ketamine, the difference. It mainly acts on the GABAergic interneurons in the subcortical and the cortical areas, and which leads to an enhanced firing of glutamatergic projections, which in turn leads to NMDA receptor and AMPA receptor activation and BDNF expression. So these are some of the neurobiological findings which has been quoted in the literature. And the next session will be continued by Dr. Arun. So this is one of the researchers' claim that we don't know how true it is. Let us wait for it. Psychedelics, when used responsibly and with proper caution, would be for psychiatry what a microscope is for biology and medicine, or the telescope is for astronomy. Thank you.
Thank you, Dr. Jabbar. May I invite the second speaker, please? And what is the time allotted for this topic?
Actually, so we have time till 12:45. So we can extend by 5 minutes if depends on this.
12:45. Okay.
12:45.
Okay. Thank you. So the second speaker may start now.
Thank you, sir. Thank you. Thank you, Dr. Jabbar. Respected teachers and friends, I'd like to continue from where Dr. Jassar has actually contributed to this area of psychedelic research. I think so. Am I audible, sir? Am I audible? No. Okay. Audible?
Yeah.
Right.
Your voice is very low, I think. Can you increase the volume?
I will try to raise the tempo, sir.
The previous speaker that was fantastic, but this time your voice is
Yes.
not very clear and very low.
Right. Audible now?
Yes, better.
Sir,
Yes, sir. Go ahead.
Yes. Sir, as we are actually running short of time, we would directly go into the second topics of our presentations. The area which I would like to actually contribute is regarding hallucinogen-assisted psychotherapy, its current evidences and future prospects. Strictly from a scientific evidence point of view, what evidences we have. See, the hallucinogen-assisted psychotherapeutic research came to a literal halt in 1970s because of restrictions. But it was actually by 1990s by the works of Rick Strassman where the evolutions of psychedelic research began to happen again. A lot of studies have been happening, particularly pertinent to anxiety disorders and depressive syndromes, which are related with end-of-life issues, PTSD, depression, as well as substance use disorders. So the format or the contents of the discussions which I would like to actually contribute is, what is the relevance of hallucinogen-assisted psychotherapy? What are the current studies regarding this particular topic? What is the much social hype notion of microdosing of LSD? What are the evidences for microdosing? What is the current status regarding psychedelic-assisted psychotherapy? A few of the controversial reports and conflicting reports about the actions of LSD, particularly in relation to perceptions in mood as well as alterations in mood. What are the current techniques which are employed in psychedelic-assisted psychotherapy? The abuse potentials for these agents. What are the areas of future research? And conclude. I believe I'm limited by time, so I will actually try to first start and go along with you if it's possible. So the relevance of psychedelic-assisted psychotherapy is a study trial had actually examined and seen the initial response of an antidepressant treatment is only 45%. And non-responders by meta-analysis have actually shown to one or more antidepressants to have a 15% suicidal ideations, which when compared to the general population is only 1%, and 6% for people who have responded with antidepressant trials. Okay. Only 30% of the clients do respond with major depressive disorder and are actually compliant with medicines. 30 to 50% of the patients, they actually do not respond to the first antidepressant trial only. the remission rates of SSRIs are dismally low, around 37%. Now, even the realms of this non-response to antidepressants comes under the realms of pharmacogenomics. There is definite relevance for psychedelic assisted therapy here. Now, the evolutions of psychiatry from a biological as well as a purely psychological perspective has actually changed. And we are actually leading into a hybrid model or a nuanced integrated network in psychiatry, where there is combinations of psychotherapy with agents involves both bidirectional as well as synergistic interactions. We are aware there is a lot of scale of unmet needs in psychiatry, which promoting results in trials suggests that definitely psychedelic assisted psychotherapy will find a clinical niche. Now, what are the studies on psilocybin? Before going into the current studies on psilocybin, let me remind you, the audience, about a historical two named experiments of psilocybin which happened in 1960s. It is the Good Friday experiment as well as the Concord prison experiment, which was actually done for reducing the recidivism rates in incarcerated individuals. The Good Friday experiment as well as the Concord prison experiments. Limitations of time, I'm just rushing in. The studies of psilocybin have been mainly restricted with, from the studies which I have, are mainly open label studies as well as randomized controlled trials pertaining to the diagnosis of treatment resistant depression, as well as cancer related depression, anxiety and depression, PTSD, coming to the forward part of the presentations, as well as tobacco use disorders and alcohol dependent syndromes. We are running short of time, so we will actually try to at least do justice to a couple of the studies. First is actually a Carhart-Harris et al. Study, which is on treatment resistant depression, which is an open label study where 10 milligrams psilocybin as well as 25 milligrams psilocybin was actually presented 2 weeks later. The primary outcome measure was actually a quick inventory of depressive symptomatology, which showed a significant reduction in the depressive symptoms. The mean change of the QIDS scores was around 11.8 and 9.8, which was actually statistically significant. Now, coming to another study, which is related to a cancer-related depressions and anxiety by Griffith et al. Study, where surprisingly, and quite interestingly, the control which was actually used was psilocybin 1 milligram or 3 milligram, along with the standard psilocybin dose of 22 milligram or 30 milligram per kg, 70 kg. So the primary outcome measures which was used was Hamilton's anxiety rating scales as well as HAM-D scales. At 6 months follow-up, the overall rates of clinical response was around 78%. The clinical response is actually a 50% improvement in symptomatic symptoms. And also the overall remission rate was actually found to be around 65%. Okay. Regarding substance use disorders, there is actually evidence from the Johnson et al. Study that 20 milligram per 70 kgs of psilocybin use has actually had 6 months follow-up. There is laboratory verified evidence of persistent abstinence. Now, what about the alcohol use disorders? This is the one study which I have on alcohol use disorders, the Bogenstulz et al. Study, where gains were actually largely maintained at around about even 36 weeks by using the questionnaire alcohol screening questionnaires. Now, the only one study which I have in my reference of a head-to-head trials of psilocybin with SSRI is the phase 2 clinical trials of the Imperial College of London study, which is a double-blind RCT done for long-standing moderate to severe depressions. They've actually compared psilocybin with escitalopram. That is, there are two arms. One is actually a psilocybin arm where 25 milligrams of psilocybin was given in 2 separate doses, 3 weeks apart, with a 6 weeks of daily placebo. The other arm was 6 weeks of daily oral escitalopram, around 20 milligram, with 2 separate doses of 1 milligram psilocybin. The primary outcome measure was again the 16-item self-reported QIDS. It is a quick inventory of depressive symptomatology. There were no significant differences in the primary outcomes in the study, and the p-value is actually not significant. However, in the secondary outcome measures, which is actually the remission rates as well as the response rate, the psilocybin scored higher than the escitalopram groups. 70% in psilocybin and 48% in the escitalopram group. And remission is 57% and 28% respectively. Yeah, this is what I actually just mentioned. However, we are not able to draw a conclusive evidence about the outcomes of the study. We further require larger and longer trials are actually required to have a conclusive evidences. And also the methodological flaws were actually there in the previous studies. This is quite better than the previous studies. Now, the studies of LSD in my references are basically on anxiety associated with life-threatening diseases, talking about malignancies, where 200 micrograms of LSD compared with a lower dose of LSD had actually had significant reductions in the primary outcome variable, which is the state trait anxiety inventory. The mean change in the state trait anxiety inventory was around 11.6. And this reduction was very well sustained even at a 12-month follow-up. The next is a study on healthy subjects, which is a randomized double-blind crossover study. There was no control. There was a persistent effect questionnaire was actually used as a primary outcome measure with mysticism scales. There is a lot of subjectivity in the last study. However, highly meaningful experiences and also lasting positive effects on the positive attitude towards self as well as social effects were actually reported from the healthy populations. Now, studies on ayahuasca, just to mention, ayahuasca is a decoction preparation which is actually pertinent to 2 native plants in Amazon basin, which is called by the names of Psychotropia viridis as well as Banisteriopsis capi. Okay, where it combines the combinations of DMT as well as harmine derivatives. Just like what my friend has actually mentioned, it is the DMT component which is actually causing the pharmacological actions. Continuing with the studies on MDMA, mainly limited to PTSD. Quite a daunting task from a mental health point of view, PTSD, when it is actually treatment resistant. Now, main studies are basically by the Mithofer et al., where a randomized double-blind crossover study on 125 milligrams of MDMA plus an optional 62 milligrams on 23 samples had revealed significant reductions in the PTSD symptom severities. The scales which was actually applied was the clinically administered PTSD scale. The second one is actually a follow-up of the first study where significant and sustained reductions in the PTSD symptoms was even reported at 74 months. See, this is the evidence. I'm talking about evidences. Can be biased, can be non-biased. Whether you take it, don't take it. But this is the evidence which is actually being shown. There is a lot of methodological flaws in the studies. The sample size is actually quite low. The blinding is actually not there. It is actually parallel kind of, it is not a parallel kind of crossover designs. So a lot of methodological flaws are actually there. So be a bit cautious in actually generalizing the studies. Okay. The last is also this again in the same run of the PTSD reductions. As I'm running short of time and I've only around about 10 to 15 minutes, I'm just rushing through. Okay. Now, a bit of sensitizations about the much socially hyped and also media hyped concept of microdosing, which is using LSDs in less doses, that is around 10 to 20 milligrams at 3 to 5 days interval, and also claiming by the medias and also by the few enthusiasts that it improves creativity and enhances mood. As far as available from the current evidences, there is no evidence of actually enhancing creativity as well as enhancing mood from microdosing. There is no evidence as such now. However, I would like to draw the attention of the audience to this particular last study by Gasser et al., where low dose of microdosing or low dose of LSD received have actually increased the anxiety in clients with medical illnesses. So it is very difficult to actually extrapolate the findings, whether it is because of microdosing or because of placebo non-effect, but definitely microdosing could be a reason. Now, the Beckley Foundation has actually come with few upcoming studies, basically on microdosing of LSD on the neurophysiological effects as well as the clinical effects on the cognitive profiles. So let the results come. So that's what it is. Let us be open. As far as now, there is no effects, there is no evidences for microdosing of LSD. Going into the current status, that is psilocybin has been approved as a breakthrough therapy in 2018 for treatment-resistant depressions. So there has been a fast pacing by the FDA for the hallucinogenic molecules, which is actually quite promising that research is actually happening. Let research happen. So the Compass Pathway, which is another agency, is actually starting a phase 2B trials for treatment-resistant depressions. Additional phase 3 studies are also being taking place. At the time of actually reporting this presentations, I was not able to get any further references for that. The Usona Institute, which is actually a US-based institute, I believe, is planning phase 2 and phase 3 trials on psilocybin for depressions, anxiety, and mood disorders. See, this is one area that is the end of life issues where there have been a lot of studies where a lot of potential has actually been reported for psilocybin. Okay. There have been 2 ongoing phase 2 RCTs on psilocybin's efficacy in OCDs also to replicate the landmark initial findings by the Moreno et al., which was the first study in 2006, which did an evidence-based study on the psychotherapeutic associations of psilocybin in the realms of OCD. Moreno et al. Now, coming to the restrictions, LSD and all the drugs are actually Schedule 1 drugs under the Controlled Substance Act. Let me be very clear. Only FDA has actually granted permissions for MDMA as well as psilocybin in few restricted conditions. Ayahuasca, that is DMT, which is a component of ayahuasca, again is a Schedule 1 controlled substance. Just like what I mentioned, FDA has actually approved in 2017 or 18 approval for MAPS, which is a multidisciplinary association for psychedelic studies, for designing 2 phase 3 clinical trials in PTSD. It has been designated as a breakthrough therapy in assisted psychotherapy for PTSD. Let me remind the audience, ketamine again was actually in the same realm. It was actually given a breakthrough therapy. Now it is actually a Schedule 3 drug for treatment-resistant depression. Now, additional trials on MDMA has been going on in social anxiety with autism spectrum disorders and anxiety associated with end-of-life issues. Now, what is the debate? The debate still exists, even though we have a very solid understanding about what are the pharmacodynamic profiles as well as the pharmacokinetic profiles of the hallucinogenic drugs. How does this molecules alter consciousness and mood? There have been conflicting reports. What are the conflicts? Okay. This is one author by the name of Wharton Vader who actually suggests psilocybin-induced metabolic changes, particularly hyperfrontality. What I mean by hyperfrontality is actually increased blood flow to the prefrontal cortex, alters thalamocortical synaptic transmissions. It actually causes increased response of the 5:2A receptors, leading to response. Now, these authors also claim thalamic gating disruptions. They actually disables the sensory and the cognitive informations. They actually causes an inhibition of the default mode network. Now, let's go a bit of the basics. Default mode network is actually quite actually active when the mind is actually a mind wandering. That is actually safe. It inhibits the default mode network so that the automatic thoughts are actually inhibited. You are able to actually live in this moment, this particular moment, which is not always the case. Sometimes we are actually in the illusion. We are living in the past. We are living in the future. You are resting the current moment. So this is where the concept of mindfulness actually comes in, where my friend would actually like to do a study on mindfulness based incorporated with LSD. Okay. Now, that is hyperfrontality. Conflicting reports by Carhart Harris et al., where hypofrontality and reduced connectivity of the neural activity of the neural default mode network has been implicated. That is, it drives the mind to a more primitive state of entropy, just like what actually I mentioned earlier only. The automatic thoughts develops. So a flexible mind is able to develop new perspectives and able to challenge the automatic thoughts. See, both these theories are actually not exclusive. They have actually raised a couple of few questions about cerebral perfusions, connectomes, thalamic gatings, and the role of serotonin, again in psychiatric disorders. Now, what are the current techniques in psychedelic assisted psychotherapy? Before mentioning about the current techniques, we have actually discussed, my friend has actually discussed, there is psycholytic versions, there are psychedelic versions, which versions are actually better, which is actually not better. But before going into that, let me mention to the audience about the name of Sir Stanislav Grof, who's actually a pioneer behind LSD psychotherapy. And all of these particular models and studies, especially, have actually borrowed the techniques from Stanislav Grof. Okay. The recent psilocybin studies implemented the psychedelic versions, as well as the recent MDMA studies have actually borrowed a psycholytic as well as psychedelic versions. See, the psycholytic versions have actually got a narrative from the psychoanalytic point of view. And the doses which is used in the psycholytic treatment is roundabout very, it's a minuscule dose compared to the high doses which is used in the psychedelic version. That is the main difference. And also the difference is that in the psychedelic version, it is more like a non-directive approach has been used. There is no aspect of exploration to the unconscious in the psychedelic versions. You let go experience, you just accept and let go. That is the kind of, but there is a bit of explorations in the psycholytic versions. It is quite unclear which version is superior. We have also to accept these compounds like the hallucinogenic molecules. They actually might catalyze or augment the widely accepted structured therapies in the forms of cognitive processing therapies, acceptance and commitment therapies, as well as interpersonal therapies. And also less structured therapies like the dynamic and the analytic versions. There is a lack of clarity whether it is a compound itself or the psychedelic associated with the drug facilitated enhancement or the therapeutic alliance that promotes the change. A statistical association between the mystical experiences and the resolutions of symptoms are actually been reported. However, there is a lot of subjectivity in the studies, and lack of qualitative analysis of individual psychotherapy sessions limits the external validity. It also limits the understandings of the cognitive or the emotional processes, which leads to particular outcomes in psychedelic assisted psychotherapy. I'm just rushing to, I think so I only have 5 minutes left, sir. Okay. The abuse potentials of LSD and psilocybin appears to be the least dangerous compounds in the recreational users in terms of harm to users and others. This reference is quite important because this particular author by the name of Dr. David Nuck, he was actually involved in quite a controversial study in 2010, which will be coming across. The potential for addiction is actually considered to be low for LSD and psilocybin. Animal models have not elicited the drug-seeking behaviors in animals, particularly for LSD and psilocybin. Now, why the abuse potential is low for LSD and psilocybin? This particular pharmacodynamic actions should be one of the explanations of tachyphylaxis. That is, receptor tachyphylaxis of the 5-HT2A receptor. What it means is that repeated exposure to the drug at frequent intervals causes reduced response. Repeated exposure of the drug at frequent intervals causes reduced response. That is it. That could be one of the mechanisms where, because the drug tolerance is not reported. The recreational use is associated with less abuse of other substances, according to this prominent author. As we know, it has been employed with success in the treatment for alcohol use disorders and nicotine use disorders. However, MDMA has been associated with moderate abuse liability in few studies among recreational users. However, not the hardcore kinds of drug cravings or substance use disorders has been seen in controlled trials. The problematic use is considered low, administered under supervision. Now, this is a particular study which landed up with the lead author from the dismissal from the Scientific Committee on Drug Counselings in UK. See, the author tried to assess the magnitude of harm for drugs of abuse to the users as well as to others in a 8-grid matrix scale of harm. And in this scale of harm, it was alcohol which actually topped the study with the points of around 75. It was actually followed by heroin with a score of 56, followed by crack cocaine with a score of 54. Benzodiazepines and ketamine, which comes under class 4, was actually 15. Ecstasy, LSD, and psilocybin was actually the bottom of the table, 975. But there are a lot of methodological flaws in the study before we can actually extrapolate these findings. So please, it has actually landed up the author in problems. And also, the author tried to redefine the methodology and do a similar study with another methodology. Still, the result was actually the same. So there are evidences, there are conflicting evidences also. Now, this is a brochure by the US-based National Institute on Drug Abuse, where hallucinogens have been mentioned as to be potentially addictive. It is not as hallucinogens like, phencyclidine has been potentially addictive, but not associated with uncontrollable drug-seeking behavior. In treatment with LSD, or let it be psilocybin, careful considerations of the setting, and the appropriate dose and the preparations of the patients is much important in therapy. A lot of adversities have been reported in settings which are actually not very well prepared. Sorry, sirs, we are actually running short of time, so I'm rushing in. So there is further evaluation for the long-term risk of MDMA is quite needed. John Hopkins is actually evaluating and suggested psilocybin should be rescheduled under class 4 if approved as a medication. Now, this is few recommendations for future research. We have actually seen in the previous studies, there are a lot of methodological flaws. The sample size is actually quite not there. There have been actually there is no parallel crossover designs. It is actually the crossover study. There is a lot of patient selection biases which has been happened. There is a lot of confounders. So what we need is actually international agencies to conduct an international symposium on clinical trial methodology for psychedelic assisted psychotherapy research. There is a lot of methodological issues which has to be addressed. The author, which I've just quoted, Sellers et al., reviewed the challenges in conducting his research in this particular area. Highly selected patient populations and many of the studies rating scales are not very well validated, especially the hallucinogen rating scales and the altered state of consciousness. That is actually the gist of it. I'm not able to go into the details. So more rigorous analysis of the treatment assessment scale is actually very much warranted. Focus on the pharmacodynamic as well as the pharmacokinetics as well as the abuse potential is also needed. To conclude, sirs, we are actually putting forward that the published evidence, although limited, it definitely supports continued research, especially in PTSD, end-of-life issues, treatment-resistant depression, and as well as in OCD for some populations. They do not support the use of this particular molecules by practitioners outside research settings. The FDA breakthrough designations for MDMA in PTSD as well as psilocybin is definitely opening up new horizons in this area of research. There's been quite an interesting data from psilocybin also, that is, which can lead to antidepressant effects persisting for weeks to months. There's been limited scientific evidence on DMT as well as LSD. Further studies are actually needed. There is definite concern about the microdosing of LSD. It was reported by the master himself, Albert Hoffman, in his autobiography, LSD My Problem Child, about the over-enthusiasm in general public, which we have to be very careful. We need further research to ask meaningful questions about the therapeutic potentials and the abuse potentials of psychedelic assisted psychotherapy. Whether monotherapy is actually efficacious. What about the adverse events with monotherapy? The use of this diverse kind of molecules with different actions and different diversity in their actions will definitely advance our understanding about the neurobiology of many of the psychiatric disorders. We have pointed out significant limitations in the study methodology. Finally, to conclude, limitations notwithstanding, the preliminary data on therapeutic potentials of psychedelic assisted psychotherapy or hallucinogen assisted psychotherapy merits further research. We thank our teachers and friends for the patient listening, and these are our references. Thank you.
Thank you, both the speakers. You have presented very nicely, and starting from history to the current situation, it is an excellent and very interesting topic. So the topic is now open for discussion if anybody wants to ask anything or can comment anything. Dr. Garg, please.
That's all. This is what I wanted, Bharat, that have we got some questions from the audience?
I think, sir,
This,
very limited audience is there. Only 7 participants is
Okay.
going in there. So there are concurrent sessions going on. So very limited participants are
Otherwise,
available.
I think now there is no time. As far as time is concerned, we are over the time. And I will
we
like
have
to.
one question. We have one
Yes.
question.
Yes, please.
Okay,
Yes,
please
please.
come.
Go ahead.
I'm Dr. M. Vijayalakshmi from AMC, Vizag. I have a doubt whether all these studies done in the past and currently are to be done are useful in India. Do we have such control for use of this medication for various disorders or for trial?
Madam, the evidences are actually quite promising. There is a lot of issues regarding the methodology of the studies which is actually mentioned. In India, I think so the main issue would be actually getting approval actually to do the studies, to sensitize about at least our community that this is one of the research has been happening in a lot of parts of the world. In Netherlands and USA, there's been active research has been going on, as well as treatment is also going on. But still, the FDA regulations are actually quite bound. They've been only been applicable for particular research purposes only. Whether it is applicable, why not, madam? People are suffering,
Yes,
end
they
of
are
life
suffering,
issues.
but we are seeing more of substance abusers rather than using medication for medication purpose.
Say, madam, most of these drugs are not actually patented drugs. So pharma companies don't have much interest in promoting such researches. So that might be one of the reasons which might create an hindrance. There is even in if you go to US or in the western parts of the countries, there are individual associations which are mainly taking up the study rather than the pharma companies, if you see. So that might be one of the limitation, and that might be a challenge for conducting future prospect studies.
Thank you.
Thank you, madam. Thank you.
So thank you, dear friends. So, well, I'm of the opinion, if there is no question, can I comment?
Yeah, sure.
So, well, I feel after going through this, presentation, that it is going to be a game changer, because there are so many problems we are facing with antidepressant, so many resistant patients of depression, anxiety, and PTSD, and alcohol, especially alcohol use disorders. So these drugs may be a useful thing in clinical practice. It will depend upon of course, on the pharma company or the legal, provisions by our country, whether they make these drugs available or not. So it will depend on all these things. So that's all from my side. And I wish to thank the organizing committee for giving the chance to me and Dr. Bharat. Can I say for you also?
Yes, sir. Yes, sir. We are together since a long time.
Dr. Bharat is a professor of psychiatry at Kota Medical College, and I am professor of psychiatry at Government Medical College, Amritsar. So we forgot to introduce ourselves. So this is the last we can say, and that's all. And let's conclude with
Yeah,
something.
I would like to ask Dr. Brigadier MSVK to felicitate our speakers behalf of the chairperson.
Yes, please. Dr. Raju, please.
Yes.
Thank you so much. We are done with this session. So next session we have is BPSS award. Thank you so much. We don't have lunch
you
break,
all.
so if anybody wants to have lunch, they'll have to just, there's no break, so you can just go if you want.
Hello, good afternoon. Am I audible? Hello.
Yes,
I'm Dr.
please,
MS
sir.
Reddy. I think the BPSS award session will start now.
Yeah, I'm just waiting for all the speakers to join, sir.
Okay.
Just give me 2 minutes.
Yes. I think the first two speakers have joined. I see them.
Yes, sir. So we can start. We have first Dr. Durva.
Yes,
She's
yeah.
already here. Also, sir, I have WhatsApped you the judge sheet. If you could just check.
So all the judges, they know that no? Whoever the judges have been designated.
Yeah, you are one of them. Then 2 of them are already present over here.
Oh, I am also one of the judges for this.
Yes, yes.
Okay, because my co-chairperson, Professor Sharma, will not be able to join for some immediate reasons. So he conveyed that apologies that he will not be able to. So I'll be conducting the session myself.
All right. We actually have 2 judges present right here. So is it
Right.
okay if I invite them on stage?
Yeah, please. Please go ahead. Can you please invite them onto the stage?
Yes, yes, yes. I'm just doing.
Yeah, please, yeah.
Dr. Shahil Amin, can you please proceed on the stage? And Dr. Shashi Rai. Thank you so much. So Dr. MS Reddy, we can start the session with Dr. Durva. She has 14 minutes.
Yes.
14 minutes of presentation time and 3 minutes for questions.
Okay, right.
All right.
Thank you very much. Thank you very much for inviting me to be the judge, like a chairperson for this session. I'll be doing it alone because Dr. Sharma will not be able to be present here. So we have 5 speakers today, 5 sessions for this prestigious BPSS award session. The first one is a comparative study of neurological soft signs in patients suffering from schizophrenia, their first degree relatives, and also patients suffering from bipolar and their first degree relatives. The speaker is Dr. Durva. I think you already know that 14 minutes for presentation, 3 minutes for the discussion. Please go ahead. All the best.
Thank you, sir.
Please go ahead with your presentation.
Is my screen visible, sir?
Yes.
Very good afternoon to respected faculty and all my dear colleagues. I, Dr. Durva Sail, Today going to present my study, a comparative study on neurological soft signs in patients suffering from schizophrenia, their first degree relatives, and patients suffering from bipolar affective disorders and their first degree relative. I would like to thank my co-author as well as my respected faculty for guiding me in this study and cooperating me for this. So, neurological soft signs, which I will be addressing as NSS, can be defined as group of minor, non-localizable neurological abnormalities, including simple motor coordination, complex motor sequencing, and sensory integration dysfunction. These are developmental abnormalities, which are partial reflection of genetic as well as non-genetic processes. So, how they are different from hard signs? So, in contrast to hard neurological signs, they are non-specific indicators of impairment. They're not associated with any brain dysfunction or any specific disease process, and they may not cause any functional impairment. So, as we all know, in late 20th century, the neurodevelopmental hypothesis of schizophrenia was put forward. Then it was found that there is increased risk for the disorder in later life due to neurobiological changes that are occurring in pre and perinatal period. Multiple studies have been carried out on non-psychotic relatives of these patients suffering from schizophrenia, where it was found that there is higher prevalence of NSS and other abnormalities, which is giving rise to genetic diathesis of neurological soft signs. Hence, when we compared multiple studies, it was found that relatives of schizophrenic patients have shown the rates of neurological abnormalities in between those two patients and normal comparison subject. Cantergray et al. In their study with monozygotic twins discordant for schizophrenia reported that neurological soft signs in both the twins are present, but they are more pronounced in the affected twins. Then, in 21st century, the research was extended to bipolar disorders as well. As we all know, the complex etiopathogenesis of bipolar disorder is an amalgamation of various biological and psychosocial factors. This leads to development of various hypotheses to explain this disorder, including neurodevelopment.
Dr. Purva, 1 second. Can you hear me? The
Yes,
slides are actually not moving. So is it like...
Just a minute. I have shared my screen.
Yeah. Now it's moving because actually it got hanged.
Yes.
So should I start from...
Can you make it full screen?
Yeah, this is full screen only. Just a
slide show you.
Yeah, I think you can go ahead. Yeah, right.
Okay, you can go ahead. Go ahead.
Okay.
Now is the screen visible? I'm not able to see the slides
now. Now she's not presenting, I guess.
Right. You are able to see.
Can you see now, sir, in full screen?
Yes, yeah.
Okay. So the neurodevelopmental hypothesis was extended in 21st century. The research was extended to bipolar disorder as well. As we know, the complex etiopathogenesis of bipolar disorder is amalgamation of various biological and psychosocial factors. This led to development of various hypotheses to explain this disorder, including neurodevelopmental hypothesis. So it was found that when it was compared the prevalence of NSS in bipolar patient to healthy control, there is increased NSS in bipolar patient with respect to healthy controls. So NSS can be constituted as marker of vulnerability to patients with BPAD. However, when comparison was done between patients suffering from BPAD and their first degree relatives, the findings were equivocal. Then the concept of schizophrenia BPAD boundary came while it was observed that there is an overlap between both the disorders with respect to genetics, neurocognition, neurophysiology, eye tracking, imaging, and NSS. Some studies showed that NSS do not discriminate bipolar disorder from schizophrenia patients, suggesting that NSS might be a shared trait in these disorders. Hence, we planned this study with an aim to determine the frequency of neurological soft sign in patients with schizophrenia and in those with bipolar disorder as well as their first degree relatives. So cross-sectional observational case control hospital-based study was carried out on 60 patients suffering from schizophrenia and their 60 first degree relatives. 60 patients suffering from bipolar affective disorder and their first degree relatives.
Dr. Dhruva,
Yes, sir.
your slides have not changed. You are still not that NSS and BPAD slide. And also you are not full screen. You never were full screen. You have to share the
Okay,
slides
sir.
to the show window. Then
sir.
the slides may change also.
Okay, sir.
You first put it in slide show, then you share that window, then you keep changing the slides, then it should work.
Okay, sir.
No, you can put it in a slideshow, no?
Yes, sir, I'm putting it, but then to
Yeah, if you're having a problem, I can go ahead with the previous kind of presentation, but the slides are not moving. See that? Move the slides.
yes, sir. So when I'm making it full screen, it is not getting moved.
Okay, then fine, go ahead with this.
Okay, sir.
At least, no, we'll see that the slides are moving. Okay?
Yes, sir.
Yeah, right. Please go ahead.
So a cross-sectional observational case control hospital-based study was carried out on 60 patients suffering from schizophrenia, 60 patients suffering from bipolar affective disorder, 60 first-degree relatives of patients suffering from each disorder. The patients diagnosed with schizophrenia, bipolar affective disorder using ICD-10 were included in their study and their first-degree relatives of either gender, and those who were willing to give written informed consent were included in the study. The patients in a state of symptomatic remission only were assessed for neurological soft signs. The remission for patients with schizophrenia was defined as PAN-SS score of 3 or less in all the atom, and remission for bipolar affective disorder was defined as less than 10 points in Montgomery-Åsberg Depression Rating Scale, that is MATRS, and less than 5 points in Young Mania Rating Scale. Those with mental retardation, epilepsy, Parkinson's disease, dementia, chronic neurological illnesses, recent neurosurgery, history of head injury, and previous or current substance use except nicotine were excluded from the study. Sociodemographic data was collected in a semi-structured proforma. The International Classification of Disease, 10th revision, diagnostic and clinical research criteria was used for diagnosis of schizophrenia as well as bipolar disorder. Part 2 of Cambridge Neurological Inventory was used for assessment of neurological soft signs. The mean age of patients suffering from schizophrenia was found to be 39.23 plus or minus 14.2 years, while that of first degree relative was 41.33 plus or minus 13.85 years. The mean age for BPAD patient was 43.07 plus or minus 14.02 years, and that of first degree relative was 14.03 plus or minus 39.69 years. The difference between the ages of either group was not statistically significant. This was a sex distribution where 31 patients were male for schizophrenia and their first degree relative, and 29 were females, and 33 patients were male of bipolar disorder and 27 were female, while 34 first degree relatives of BPAD patient were male and 26 were female. This sex difference was also not statistically significant. The patients with schizophrenia had statistically significant more neurological soft sign than their first degree relatives, and p-value was less than 0.05. The patients with BPAD didn't have significantly more NSS than their first degree relatives. Patients with schizophrenia had more neurological soft sign than patients with BPAD. However, no significant difference was found between the first degree relatives of patients with either disorder. The most common neurological soft sign observed in patients with schizophrenia as well as their first degree relative was Osseretsky sign. The most of the patients perform poor on motor coordination and sensory integration. So did their first degree relatives in schizophrenia. The patient with schizophrenia had statistically significant higher score than their first degree relatives in palmomental reflex, finger nose toast, fish edge palm test, Osseretsky sign, rhythm tapping test, go no go test, and finger agnosia. Most common neurological soft sign which was observed in patients with BPAD as well as their first degree relative was fist edge palm test. The most of the patients perform poor on test of motor coordination as well as their test of sensory integration. So did their first degree relatives. No statistically significant difference was observed between the patients with BPAD and their first degree relative in any individual test. The mean age of patients with schizophrenia was comparable with some studies like Chobrak et al., where they found the mean age of 37 years, and Rigusi et al., where they found the mean age of 34.9 years. Multiple studies have given the range of 15.4 years to 37 years. This might be due to difference in inclusion and exclusion criteria for various studies. The mean age of patients with bipolar affective disorder was also comparable with some studies. While in Chobrak et al., they found the mean age was 42 years and Bass et al. Found a mean age of 38.3 years. The multiple studies have given the range of 12.5 years to 42 years. Like multiple studies, our patients were also on antipsychotic and mood stabilizer. Several studies have compared NSS in patients taking antipsychotic and those who are antipsychotic naive, but they didn't find any statistically significant difference between the same. Similarly, no significant difference was observed among those who are on mood stabilizers, including lithium. Similar to our study, multiple studies have found excess NSS in their first degree relatives of patients of schizophrenia. This presence of NSS indicates the potential genetic loading. This further suggests familial association of the same. In line with our study, Sharma et al. Were unable to establish the higher prevalence of NSS in BPAD patients than their first degree relatives. However, Rad et al. Found higher prevalence of NSS in patients with BPAD than their healthy siblings. Rigusi et al. And Robin et al. Concluded that NSS total score was higher in patients in schizophrenia than in bipolar disorder, like our study. Tobar et al. Found that relatives of schizophrenia differ significantly from relatives of bipolar group only on test of integration of sensory information. This is not in line with our study. Some consider failure of integration between motor system and sensory system and subcortical system as underlying reason for NSS. Dysfunction of striatothalamofrontal and frontocerebellar circuit can be considered as possible explanation for impaired motor coordination. Reduced volume.
Just one sec, just 2 minutes left for your presentation.
Yes, ma'am. Reduced volume of left medial frontal cortex and right superior lateral parietal cortex can be possible underlying pathophysiology for sensory integration abnormalities as depicted in few studies. These circuits are known to be involved commonly in schizophrenia and mood disorder as well. This study has stressed on the need to screen and identify the link between endophenotypes like neurological soft signs with underlying etiologic mechanism in schizophrenia and BPAD. This is one of the fewer studies that has compared NSS between first degree relative schizophrenia and BPAD using standardized scale. Our study has a limitations itself too. Because as it was a cross-sectional hospital-based study, it need not represent general population. Also, duration of illness and psychotic features in bipolar disorder and number of episodes were not taken into consideration in our study. To conclude, patients with schizophrenia had more NSS than their first degree relative. However, in patients with BPAD, we didn't reciprocate the same. The patients with schizophrenia had more NSS than patients with BPAD, while no difference was observed between the first degree relative of two. The most common neurological soft sign observed in patients with schizophrenia was Osseretsky, and in BPAD was fist-edge palm test. And most of the patients perform poor on motor coordination and sensory integration tests. So, NSS can be potential endophenotypes for patients suffering from BPAD as well as schizophrenia. This study, along with other studies, suggests the role of common genetic or environmental factor in the pathogenesis of these abnormalities in this disorder. The more research is required comparing NSS in patients and first-degree relatives, as studies have equivocal finding in BPAD. Most of the studies have involved small sample sizes, making it difficult to control for all variables, resulting in great variability from one study to another. Hence, further research is needed to clarify the same. These are my references. Mark Twain has correctly said that it is wiser to find out than suppose. Hence, we should carry out more research to find out the association between the same. Thank you.
Thank you. Thank you very much, Dr. Durva. Good presentation. Now
Thank
it's
you.
open for discussion. We have 3 minutes. We can take maybe 2-3 questions.
Dr. Durva, it was a very nice presentation. I
Thank
just
you,
want to
ma'am.
ask one question. What would be the clinical significance of this study? Like
So,
say for a
ma'am,
practitioner, what would it imply?
yes, ma'am. So this like NSS can be the endophenotypes for both BPAD and schizophrenia. So we can just screen their first degree relatives as well, who might be at a higher risk for development of disorder in further. So that can be one of the major clinical implications for this.
You said
So as
that
an
you had
routine-
ruled out
Yeah, please go ahead.
You had ruled out the patients who had dementia. How was
Yes,
that done?
sir.
How was that? How did you rule out dementia?
Sir, we took the detailed clinical history, and then like if the patient is having any symptom like forgetfulness and all, and then if any doubt is there, then we applied MMSC also to rule out that there is no cognitive like.
Are there any more questions?
There were some specific associations between specific signs and illnesses. No, in bipolar you had that fist palm. In schizophrenia you had that.
Stage palm test. Yes, sir.
How exactly do you explain those specific associations?
Sir, it can be like fist-stage palm test is a test for motor coordination, like complex motor sequencing. So the tracks which are involved for those. So we can see that those networks are involved in motor disorder, mood disorders as well. So that is how, but different studies have found association between different tests, but they are mainly in motor coordination, and like they are finding that it is more pronounced association. So those frontostriatothalamic tracts and frontocerebellar circuits which are involved in motor, which are responsible for this motor sequencing, they are involved in schizophrenia and bipolar both. So this can explain this association.
Okay, Dr. Durva, thank you very much.
Thank
I
you,
think
sir.
we'll move on to the second paper. This is by Dr. Pavitra Jaishankar. The title is "Are the Collaborative Video Consultations Module Diploma in Primary Psychiatry Program Helpful?" I think Dr. Pavitra, you can start your presentation. 14 minutes for presentation and 3 minutes for the questions. Please start.
Thank you very much, sir. Are my slides moving?
Yes.
Thank you. Good afternoon, one and all. I'm Dr. Pavitra Jaishankar, a senior resident working at Department of Psychiatry from National Institute of Mental Health and Neurosciences. At the outset, I would like to thank my entire team for giving me this opportunity and guiding me throughout, and ANCIPS organizing committee for giving me this opportunity to present present our study. Let's get started. Our collaborative video consultation module in Diploma in Primary Care Psychiatry program helpful. So the background of our study was, in India, according to National Mental Health Survey 2016, the overall prevalence of psychiatric disorders was 10.6%. And the treatment gap of any mental disorder was 83%, which is very huge. In order to address this concern, empowering the primary care doctors in identifying, assessing, and managing first-line psychiatric illness in a primary care setting is a feasible strategy given the country's inadequate psychiatrist to patient ratio. It can be achieved through task shifting and task sharing approaches to address the treatment gap, and thereby integrating mental health to general health. So we found that the primary care doctors can be trained to treat mental illness starting from the board's committee considerations. One of the innovative approaches we followed in training primary care doctors were conducting a diploma in primary care psychiatry program at telemedicine center from NIMANS, which is a 1-year module-based, digitally driven hybrid training program for in-service MBBS doctors. This DPCP program was designed to cater to primary care doctors training in psychiatry with minimal disruption to their routine clinical duties. The curriculum followed here in the program was the clinical schedules of primary care psychiatry, which is an adopted and validated manual for primary care doctors. This program has got 6 training modules. The first is the curriculum module, as explained earlier. This provides the first line safe and effective pharmacotherapy for commonly prevalent 6 psychiatric disorders, which include tobacco addiction, alcohol addiction, psychotic disorders, depressive disorder, anxiety disorder, and somatoform disorder. The second is the basic on-site module, which has 10 days of on-site residential training at NIMANS, which includes both consultation-based training and classroom teaching. The third module was video conference-based continuing skill development, which are the interactive sessions in the form of seminars, case conferences, and expert lectures conducted once in a week with the primary care doctors. The next module was collaborative video consultation module called a CVC, which is a primary care doctor-driven live and real-time video-based assistance by the telepsychiatrist. The last module is the public health module. Here, the primary care doctors design public education material and develop health talk or initiatives. Coming to our aims and objectives of the study, the aim of our study was to examine the utility of collaborative video consultation, CVCs, in capacity building of primary care doctors. Hence, we came up with 2 objectives. The first one being how accurate the primary care doctors are able to diagnose psychiatric disorders. The second one being what are the primary care doctors' learning points after each discussion with a telepsychiatrist at the end of CVC session. Here comes the methodology. This was a retrospective chart review with data collected from collaborative video consultation module from the Diploma in Primary Care Psychiatry program, Bihar. So this was conducted in the state of Bihar in all the DMHPs. The red pointers shows the district where the primary care doctors were enrolled. 22 primary care doctors from 21 districts were enrolled, and this was conducted over 1-year period from February 2020 to March 2021. Coming to the CVC module in a little bit of detail, this can be equated to a second opinion case consultation, and this is an instant video consultation sought by the trainee primary care doctors from the telepsychiatrist, which is a real time and a second opinion. It is based on the principle of practice-based learning, whereas the primary care doctor start the CVC module only after finishing 3 modules, the basic on-site module, curriculum module, and minimum of at least 1 tele-OCT session. It is also based on the hub and spoke model of this telepsychiatry, where the hub is at NIMANS, where the telepsychiatrists work, and spokes are the primary care doctors residing in the district DMHP in Bihar. Some of the salient features of the CVC module were the primary care doctors choose the case to be discussed with telepsychiatrists where they have some doubts or they need some clarification regarding the particular case. And hence the telepsychiatrist would be available in all the working days and hours for the primary care doctors, and also for emergency cases, SOS basis. And there happens a collaborative engagement between the telepsychiatrist and the primary care doctors because already some bit of basic learning has been happened in the previous modules. So after the end of each CVC session, there is a semi-structured pro forma developed by the team for data entry by the telepsychiatrist, which consisted of case description, the diagnosis by the primary care doctor, and telepsychiatrist diagnosis, management given for that particular patient, and some of the learning point in primary care doctor verbatim were recorded in the sheet. And our study, after getting all the data at the end of the 1 year, we compared the diagnosis made by the primary care doctors and telepsychiatrist was done, and diagnostic concurrence was evaluated using CAPA agreement. For our second objective, screening of all the learning points, the verbatims of the primary care doctors were done by the investigators, and predefined learning themes were generated. And these themes were analyzed using descriptive statistics, and data was analyzed using SPSS version 27. Coming to the results of our study, totally 15 primary care doctors out of 22 would complete the CVC module in 1 year, and 217 CVC cases has been discussed in the 1 year period. So coming to the socio-demographic profile of the cases, The mean age of the patients were 34.84 years with standard deviation of 15.75, of which 67.7% were males and 31.3% were females. The distribution of psychiatric diagnosis were divided for the sake of convenience into CSP diagnostic schedule and non-CSP, which we have used ICD-10 taxonomy. The CSP, the curriculum, based on the curriculum module, the diagnosis made by the telepsychiatrist and the primary care doctors. The distribution of psychiatric diagnosis, we saw that around 29.6%, that is 64 cases were psychosis, followed by 25 cases of generalized anxiety disorder and 20 cases of depressive disorder and 13 cases of mixed anxiety depression and some cases of somatization disorder, alcohol disorder, tobacco addiction, and also panic disorder. Among the non-CSP diagnosis, those diagnoses which doesn't come under the curriculum module, those were also diagnosed. We found that those were also diagnosed by primary care doctors because of the learning which has happened through the on-site consultation-based training module and also through the expert lectures and the interactive discussions in the continuing skill development module. And we found that around 13 cases were not yet diagnosed, which was later referred for a psychiatrist opinion during the CVC session. And there were cases on opioid dependence, cannabis dependence, sedative or hypnotics dependence, and polysubstance use, and 4 cases of obsessive compulsive disorder, dissociative disorder, personality disorder, and intellectual developmental disorder. Coming to our first result, we found that 84% of primary care doctor diagnosis were concordant with the telepsychiatrist diagnosis with kappa agreement of 0.75, which was statistically significant. This was the overall CVC cases concordance. And next, doing a CSP concordance and non-CSP concordance, we found that 87% of primary care doctor diagnosis were concordant with the telepsychiatrist diagnosis, and 75% of non-CSP diagnosis made by the primary care doctor were concordant with the telepsychiatrist diagnosis. And among the diagnostic discordance, I have tabulated here the distribution of the diagnosis. We could find that, for example, we could see that 4 cases of psychosis diagnosed by telepsychiatrists were diagnosed as depressive disorder by primary care doctor, and 3 cases of depressive disorder diagnosed by telepsychiatrists were diagnosed as sleep disorder by primary care doctor, and so on. Coming to our second objective. So from the predefined, from the learning points given by the primary care doctors, these are the learning themes which were generated, which was very diverse, which ranges from enhancement of clinical skills, learning areas of error, handling difficult cases, identification of referral red flags, and so on. We could find that around 35.5% has given that they have acquired enhancement of clinical skill at the end of the CVC session. Followed by 12.5% on the pharmacology and 10.1% on psychopathology, and so on. Of the total CVC consultations, 83% had diagnostic concordance with kappa agreement of 0.78. This means that the primary care doctors were able to diagnose most of the cases which reflect on the overall effectiveness of the program. Also, the CVC module, the collaborative video consultation module, helped PCDs to sustain confidence, secondary to real-time positive feedback experience, which happens during the CVC session by the telepsychiatrist. The discordance of 17% also gives feedback to the telepsychiatrist to enhance the current existing module, and it also helps PCDs to identify their areas of error and bring it to attention of telepsychiatrist either in the CVC session or in the other interactive sessions as well. And coming to the description of the learning themes, the learning team showed that 35% resulted in skill enhancement at the end of CVC session, which is in line with the objective of our CVC collaborative video consultation module, which means to say that the basic training would have been done in the previous module itself, and the collaborative video consultation essentially resulted in the skill enhancement. Also, we found that the learning themes were quite wide and comprehensive, ranging from understanding psychopathology, learning psychopharmacology, or the identification of referral red flags, and handling the special population at the screening level. In contrast to the traditional classroom approach, the CVC is based on the adult learning principle, where they learn through practice, where the primary care doctors learn through practice. Also, it promotes collaborative engagement between primary care doctor and the telepsychiatrist, which in turn will enable primary care doctors to provide collaborative care under DMHPs and in their programs as well. This also shows that the use of the feasibility of use of digital technology in capacity building in the primary care doctors. And CBC module itself here in this program itself served as an outcome measure because it was conducted after the completion of 3 modules. And it was found that it is effective than the other direct CBC consultation because it also promotes capacity building of the primary care doctors. One of the limitations we found in our study was it was a retrospective analysis. And coming to the strengths of our study, it is a first study to evaluate the effectiveness of diploma in primary care psychiatry program through diagnostic concurrence. And we also had a qualitative component for the description of learning themes, which add to the value of the study. Hence, to conclude, our study has showed that there is a positive impact of the CBC module and the overall diploma in primary care psychiatry program in capacity building of primary care doctors. And also we suggest that the capacity building training programs can employ similar principles for improving the capacity building and training of the primary care doctors. So some of the future directions could be to study patient acceptance and the clinical outcomes, which would essentially give us the translational effect of this diploma in primary care psychiatry program, how it addresses the treatment gap and how it integrates with the primary care setting. And also to study overall cost effectiveness and comparison of various training formats could be done, whether how much it is cost effective through this digital or the tele mode, and how much it is effective compared to the other training programs. These are my references. Thank you.
Thank you. Thank you very much, Dr. Pavitra. You have finished well in time. Now it's open for discussion. Any questions? Any questions on the present topic which has been presented? Okay, if there are no questions, thank you very much for a good presentation. We'll move on to the third topic. Topic that is by.
Sir, we have a question, sir. There was some issue with the mic. Please. So I had a question, like the studies basically on the primary care doctors. The sociodemographic information you shared was that of the patients that they were seen. So do you have any information about these doctors? Like what was the gender distribution? How many years they have been in the practice? What is their qualification? That kind of information do you have?
Yes, sir. So there were around 22 primary care doctors who had enrolled into the program, and all were in-service MBBS doctors. That is post-MBBS doctor who are working in the primary healthcare and the or the district hospital in setting as a general practitioners. And their service experience ranged from between 1 to 5 years of service. And most of the primary care doctors, I think all the primary care doctors were males.
Just one more question. Like you said, it was a retrospective study, isn't it? And there was enhancement of skills in about 35% of the patient. So was the test done earlier also? I mean, before the doctor started, where what the diagnosis they were making, was it, analyzed?
Meaning before the start of the program, ma'am?
Before the start of the study, like it was a retrospective study, isn't it?
Yes, ma'am. So
how did we come to the conclusion that there was enhancement of 35%?
So the learning themes were part of the data, were the part of the proforma which was followed by the telepsychiatrist to record at the end of each CVC session, ma'am. So one of that was the learning theme, where they had collected some verbatim from the primary care doctor at the end of the session to just know whether they have understood the particular discussion or not, or whether how they have imbibed a new skill at the end of the session. So that was the aim of initially when the data was collected, when the CBC session was recorded, that was data which was available. So retrospectively, we have taken out all these verbatims, and then we have defined some learning themes. We have generated common learning themes out of it, and out of which we found that 35.5% of primary care doctors had, of the CVC session, primary care doctors had opined that there was enhancement of the clinical skills. And the baseline knowledge or baseline clinical skill of the primary care doctors were not assessed, ma'am. It was retrospective review after the completion of the diploma program.
Okay, thank you.
Thank you, ma'am.
Thank you very much. Then we will move on to the third topic. This is about efficacy of intensive bilateral temporoparatal continuous theta burst simulation for auditory verbal hallucinations in schizophrenia, a randomized sham control trial by Dr. Shobit Garg. Dr. Shobit, you can start your presentation.
Thank you, sir. My slides are visible?
Yes.
So the title of my presentation paper is Efficacy of Intensive Bilateral Temporoparatal Continuous Theta Burst Stimulation for Auditory Verbal Hallucinations in Schizophrenia, a randomized sham control trial. We know that auditory verbal hallucinations affect 60 to 80% of patients with schizophrenia, and it leads to reduced self-esteem, anxiety, depression, dysfunction, and maybe suicidal tendencies. And we know that 25 to 30% of patients' auditory verbal hallucinations do not respond to antipsychotics. Other alternative treatments like CBT may reduce the burden, but not effective in reducing the duration or intensity. Hence, novel and effective treatment strategies are needed. RTMS, we know, can non-invasively modulate specific brain regions to dissipate auditory verbal hallucinations. Converging evidence tells us that temporoparietal cortices is a critical node underlying auditory verbal hallucinations. Most studies have used low-frequency RTMS to left temporoparietal cortices, but as per recent reviews and meta-analysis, the findings are mixed, inconsistent, and with every meta-analysis, there is decrease in effect size. And also, low-frequency RTMS is time-consuming. And then now a novel paradigm of TMS, that is theta burst, which takes lesser time. This is long-lasting effects and is metaplastic, has come into the picture. And CTBS is equivalent to low-frequency RTMS as far as the physiological brain separation is concerned. And we have seen that CTBS of temporoparietal cortices in auditory verbal hallucinations, the available evidence till now is still anecdotal. And we also have come to know that auditory verbal hallucinations have shown lack of localization when compared to normal speech perception. More so, right TPC is involved in determining speaker identity and intentionality and involved in genesis of auditory verbal hallucinations. So with this background, we aim to study the efficacy of continuous theta burst stimulation targeting bilateral temporoparietal cortices for the treatment of auditory verbal hallucinations in schizophrenia. And on a randomized rater-blinded sham control design. The primary outcome of us is to compare the severity of auditory verbal hallucinations among active and sham group. And secondary objective is to compare concomitant depressive symptoms, effect on cognition, and global illness severity among both the groups. The site of the study was Guru Ram Rai Medical College in Uttarakhand. The study is approved by Institutional Ethical Committee and is registered in CTRI. So we basically calculate the sample size using a priori is using G-power tool. The prior meta-analysis showed the effect size of 0.27 taken into this effect size targeting at least medium effect size with power of 0.9, alpha error of 0.05, number of groups being 2, measurements being 3, 25% dropout rate. The total sample size came out to be 50, that is 25 in each group. So coming to inclusion criteria, so we included patients from 18 to 59 years of age, right-handed, fulfilling the ICD-10 DCR criteria for schizophrenia, and verbal hallucination severity of at least 3 or more as per P3 item in PANASYS, and inadequate response to at least one antipsychotic drug trial at a maximum tolerable dose in more than 6 weeks. But it was a retrospective trial. We excluded patients who had significant head injury, surgery, neoplasms, malformations, neurodegeneration, seizures, or history of ECT in past 6 months, pacemaker, or in any other metal parts in the body, and diagnosis of substance use disorder except nicotine and caffeine. We randomized the patients into 2 groups using block permuted randomization, where these kind of blocks were created and subsequently put in these opaque seed envelopes, which was opened prior to enrollment of the patients in either of the groups. So ultimately, we assessed 81 patients for the eligibility, but we had to exclude 22 of them because they didn't meet exclusion criteria. Some declined to participate and some were not ready for inpatient admission. Subsequently, 59 patients were randomized in active and placebo groups, 30 and 29. And out of them, total of 4 patients, they lost to follow-up, and 3 patients discontinued treatment due to lack of benefit, and 2 patients in sham group developed febrile illness. Subsequently, 25 patients in each group were analyzed. And all the patients were inpatient. They went through routine physical examinations, including ECG, and they were admitted for 2 weeks duration. Subsequent follow-ups were done on post-discharge. The psychotropics dose were kept similar during the entire duration of trial, and none of them received any kind of psychotherapy. Now, coming to stimulation parameters, we stimulate these patients with this MagVenture MagPro R3 device with theta burst boosters and these B65 sham and active coils. And standardized 1020 EEG system was used for positioning of TMS coil, that is midpoint of T3 and P3 or T4, P4 was assessed by 1020 EEG system. And this CTBS paradigm was given. It's a special paradigm, and 600 pulses per session were given. Right TPC followed by left TPC. So that is total of 1200 pulses per day. They were given for 5 days a week for 2 consecutive weeks. Total of 20 CTBS sessions were given, and this is known as intensive protocol. Subsequently, the patient was also assessed on clinical measures like PANSS, auditory vocal hallucination rating scale questionnaire, which is subjective questionnaire, psychiatric symptom rating scale, auditory hallucination scale, which is objective questionnaire, objective scale, Calgary depression rating scale for depression in schizophrenia, the schizophrenia cognition rating scale for cognition, and clinical global impression severity. Now, patients were assessed at baseline, subsequently after 20th session, that is on 15th day, and subsequently 2 weeks post CTBS. We blinded the subjects by, all the subjects were rated by independent rater. Patients were also blinded to treatment arm. The raters were subsequently asked to guess in which arm, based on the pre and post psychopathology scores, in which arm of the patients went to. And we actually made this guess matrix, and the kappa coefficient showed a good integrity to the blind. But integrity of participants blinding was not assessed in this study. The analysis was done using SPSS 28. Before comparing both the groups, normality tests were done using normal probability plot and conglomerate syndrome tests. And 3 variables: duration of illness, cloproprazine equivalent dose, and motor threshold. They didn't pass tests for normality, and Mann-Whitney tests were done for all these 3. Subsequently, ITT analysis, which is the main analysis in our study, was done for all the participants, irrespective of whom completed the study. The participants who didn't complete the study, their last observations were carried forward. Supplementary per protocol analysis were done on the patients who only completed the study. A mixed model ANOVA was applied. So when we see this comparison of the socioeconomic, all the demographic and clinical variables, so the sham and active group were comparable across all the continuous and categorical variables, and no major side effects were reported. The 9 patients reported headache, which was transiently responded to analgesics. Now the patient could discontinued the trial due to side effects. Baseline, both the groups were, the clinical variables were equal, except for PANSS, general psychopathology scores. In intention to treat analysis, amongst all the clinical variables, there was significant group into time effect was found. But when we used covariates, subsequently, many of the variables lost significance, and variables like PANSS positive score, total score, AVHRSQ, CIRATES AH, and CGI retained significance. So this tables also reiterated the same findings. So response rate for AVH, we actually calculated the response rate by change of CIRATES AH from baseline to the 30th day by 25% of reduction, and we could see an odds ratio of 5.6. So in PP analysis, also per protocol analysis, significant group into time interaction after inclusion of covariates are retained for all the clinical variables except for patient and informant scores for cognition. Now, coming to discussion, our study was one of the first randomized controlled trials sequentially targeting right and left TPC for auditory verbal hallucination with a large sample size. We found that bilateral CTBS showed statistically significant improvement in all the domains of clinical measures we assessed, but when confounders were used, the significance persisted only for positive symptom scores and global impression, including auditory verbal hallucinations. It implies that initial improvement in negative symptoms and depression was secondary to improvement in auditory verbal hallucinations. Our study also archives the prior trend by Plevia et al., which employed bilateral 15 sessions to temporoparietal cortex. It was a pilot study. There was a recent study, negative study, which employed these similar paradigm, but only 10 sessions to only left TPC. So this reiterates our fact and our study supports that there is a lack of lateralization of auditory verbal hallucinations related hyperactivity when compared to normal speech perception. And CTBS 1200 pulses per day over bilateral TPC have led to inhibitory neuroplastic effects leading to reduction in auditory verbal hallucinations. Now, a very interesting recent study has actually showed this, that when we actually stimulate this TPC, there is actually bilateral lobe influences or neuroplastic changes seen, like enhanced amplitude, low frequency fluctuation in left superior frontal gyrus, and gray matter volume changes in right inferior temporal cortex. So this actually also supports the bilateral stimulation which we have done in our study. So the strength of our study is we are the first to stimulate bilateral temporoparietal cortex, and it is a full design study. And we use intensive CTBS protocol, which was pragmatically implemented in order to save time so that patients need not follow for 3 to 4 weeks to get the CTBS sessions. So we actually capsuled it in 10 days. And despite this robust protocol, it was very well tolerated and adverse side effects were reported. But limitations of a study was the duration still was of short follow-up. We could follow them 15 days subsequently to the last session. We didn't use neuronavigation to target specific cortical sites, and biophysical models could have been used in order to actually assess better scalp to cortex distance. And retrospective consideration of one failed trial of antipsychotic could be prospective, and extrapyramidal side effects were not controlled in a study. So in order to finally to conclude, our study concludes that intensive bilateral temporoparietal cortices CTBS stimulation in schizophrenia is well tolerated and has clinically significant effect in auditory verbal hallucinations and overall illness severity. Thank you. These are my references.
I'm sorry. Thank you very much for a good presentation. You presented well within the time. Now it's open for questions. If I may ask one question, you said the theta burst. Now, except for the duration of the treatment, which is, I suppose it's about 3 minutes?
Yes, sir. So it is 40 seconds for CTBS, sir, even shorter.
Compared to the low frequency theta burst, except for the time difference of 20 minutes and 3 minutes, do you see any other advantage with theta burst?
Sir, the neurobiological or neurophysiological models of theta burst have actually said that the effects would last for much longer period of time. And the excitatory or inhibitory effects on the brain are much more and stronger. That is why it is more metaplastic, sir, when we compare it to the plain formulations.
Thank you. Any other questions? Any questions from the audience? Yes.
None from the floor, sir.
Okay, in that case, it's a very good and actually very interesting presentation also. Thank you very much, Dr. Shobit. We'll move on to the next topic, which is psychological morbidity and dissatisfaction with body appearance among patients with acne. Dr. Swapnajit Sahu.
Yes, sir. Thank
you. Yes, yeah, please go on.
Sharing my screen. Thank you, sir. Is my screen visible?
Yes.
Yeah. Respected judges and all the members watching this session. So I'll be presenting the topic psychological morbidity and dissatisfaction with body appearance among the patients with acne. This study was conducted in our setup in PGI Chandigarh. As we know that as early as 1948, it has been stated that there is not a single disease which causes psychic trauma and more maladjustment, general insecurity, feelings of inferiority, complex, and greater sums of psychic assessment than does acne vulgaris. So as early as 1948, it has been postulated that acne vulgaris also has significant psychological impact. Now, various studies have tried to find out what are the various psychological impact, and they have found that acne vulgaris can lead to low self-esteem and low confidence. It can lead to poor eye-to-eye contact. It can lead to avoidance behavior. There are evidence of anxiety and depression in patients with acne vulgaris. It also leads to dissatisfaction with body appearance, mainly the facial appearance. Also, it can lead to fear, shame, bullying, and embarrassment. Some studies have also reported that it can lead to suicidal ideation in the adolescent, and also it can lead to poor interaction with the opposite gender, mostly with the strangers, and also many patients with severe acne vulgaris prefer to stay homebound. So there are several studies which have tried to find the prevalence of anxiety and depression, and it has been found to be around 18 to 44% across various studies. And also some studies which have compared the emotional and psychosocial problems with patients with acne. It has been found that it is similar to that those with patients with arthritis, back pain, epilepsy, cancer, and disabling asthma. And when compared acne with other dermatological disorders, it has been found that higher incidence of clinical depression and suicidal ideation is there in acne as compared to alopecia areata and mild to moderate psoriasis. Now coming to acne and body dysmorphic disorder. Patients with body dysmorphic disorder have an obsessive preoccupation with imagined or slight defects of their appearance, which is small or non-existent. Most common body dysmorphic features or
Dr. Swapnjit, sorry to interrupt you. Your slides are not moving.
It's moving in my screen. Is it visible?
No, it's not yet visible. It's not visible.
Is it visible?
No. It's visible.
Okay.
Yeah.
Is it visible now?
It's visible, but only, I mean, I think you have to put it on slideshow so that it will move further. The first slide is, just the first slide is being shown.
Okay. Is it visible now?
Yes.
Now it's fine.
So most common related to BDD symptoms are related to nose. Patient complaints about deviation of the nose, eyes. Acne is related to skin and hair thinning, with acne being one of the most prevalent concerns. Dermatology clinics have reported BDD prevalence to be around 2.5 to 15%, and cosmetic surgery clinics have reported to around 54%. Among all these psychological morbidities in patients with acne, dissatisfaction with body appearance is least studied. Now, the lacuna in research is that although there is considerable data about the psychosocial impact of acne from the Western countries, comparable data from India and other developing countries which have a different psychosocial milieu is lacking. Also, in acne, the face is the most commonly affected area, which is an important aspect of one's perception of body image. In today's world, the media promotes seemingly perfect face, body, and complexion, which contributes to body dissatisfaction among patients with acne and contributes to significant distress. Also, no previous study from India has evaluated the prevalence of body dysmorphic disorder in patients with acne. So the aim of our study was to evaluate the psychological morbidity level of stress, dissatisfaction with body appearance among patients with acne, and to examine the relationship of body dissatisfaction with psychological morbidity, stress, and severity of acne. It was a cross-sectional exploratory study which was carried out in the OPD clinic of Department of Dermatology, and the study population of patients with acne vulgaris, and it was approved by the Institute Ethics Committee. The inclusion criteria, we took patients with acne who provided informed consent of either gender, aged more than 18 years, able to read English and Hindi, and who were on regular follow-up in the dermatology OPD for at least 6 months. And we excluded those who did not provide informed consent or who had comorbid chronic physical illness, and those who had previously diagnosed mental illness or receiving any psychotropic. All the eligible patients were initially assessed by a qualified dermatologist, mostly a senior resident or a consultant, dermatologists for grading the severity of acne as per the criteria given by Tukatne et al. In 2003, which is that acne can be graded into 4 grades. Grade 1 is comedone, grade 2 is papules, grade 3 is pustules, and grade 4 are messy abscess and cyst. So then the patients were evaluated on for PHQ-9, GAD-7, perceived stress scale 10 item, and BDD questionnaire of dermatology version. This is the questionnaire which I'll be describing later. And as per this, the cutoff, if the patient is screen positive for BDD, if he or she acknowledge the preoccupation with appearance and report at least moderate, that is more than equal to 3 level of distress or impairment in functioning related to preoccupation. Now coming to results and discussion, I will be discussing the important points side by side along with the references which will be mentioned. So we took a total of 115 patients with diagnosed acne vulgaris and were evaluated. In the whole sample, the mean age was around 21.8 years, and male comprised of 28 patients and females were 87 patients. Mostly were unmarried, and they belong to the urban locality, and all of them had a mean duration of illness around 40 months. Now, as per the grading of the severity of acne, most of the patients had grade 2, but males had around grade 3, 53%, and females are mostly in the grade 2, which was statistically significant. With regard to the PHQ severity, most of the patients had mild degree of depressive symptoms, but the males had around 14 to 17% and moderate to severe, and females are mostly mild depressive symptoms. With regard to the perceived stress score, around 80% has reported moderate stress, and there was no statistical significance between males and females. With regard to the anxiety, around 23% reported anxiety to be present when the GAD score was more than 10. With regard to both anxiety and depression, around 32% reported having presence of both anxiety and depression. So these findings were similar to the within the range of the existing literature, which is around 20 to 93%. And it is also well known that stress has a direct relationship with appearance of acne. And in our study, we found around 80% of the patients reported moderate degree of stress. With regard to the assessment of the body dysmorphic disorder, we use this questionnaire, that is BDD dermatology version. And the first question was that whether they perceived some part of their body to be especially unattractive. Around 60% reported yes, and mostly were reported by the females. And if they find it to be hard to stop thinking, around 51% of the females mostly reported they find it difficult to stop thinking about their acne, which was statistically significant. And what bothers you the most, they reported around awkward appearance to others, self-perception of not looking good, and how they were preoccupied with their appearance, what had on their life, they felt discriminated by others and stress, which was also more in the females. Next, how this defect has caused a lot of distress. Around mild to moderate distress was reported by the whole group, with mild distress by the females mostly, and some percentage of the males also reported severe distress. And mild interference was reported by around 17%. And with regard to the how if they avoided anything because of the defect, around 33% reported that they avoided various things because of their defect. So with regard to the cutoff score, body dysmorphic disorder was present in 27% of the sample, with females comprising of 31% and males 14.3%. So this 43.3% of the patient expressed preoccupation, which is similar to previous studies, and facial flaws have been reported as the most concern in the present study, which is also supported by the existing literature. Now, when we compared those with BDD present with those with absent, we found that those who had BDD, they have moderate to severe level of PHQ-9 score, that is depressive symptoms, and also they had higher stress score, and also the presence of anxiety was higher in those who had body dysmorphic types of features. So, and when we run the correlation analysis, we found that the duration of illness had a significant positive relation with the stress, anxiety, depressive scores, and body dysmorphic disorder scores. However, the severity of acne did not have any correlation with any psychiatric comorbidity. So the strength and measure findings of my study were that around 44% of the participants had the presence of preoccupation with appearance, and 27% being found to be positive for BDD. To the best of our knowledge, this is probably the first study from India in patients with acne which are evaluated BDD. Patients who screened positive for BDD had more often psychiatric morbidity and stress, And the main findings were that the significant proportion of patients with acne avoided social and occupational function, resulting in social isolation, interference with their work, job, interpersonal problems, and also it is associated with significant dysfunction, and efforts must be made to manage the same adequately. Limitations of the study were that it was a cross-sectional nature of study, and hence a cause-effect relationship could not be established. It was a small sample size. We used screening questionnaire to assess psychiatric morbidity. The variables which can possibly influence the psychological impact of acne, like the history of isotretinoin use, treatment failures, ongoing stress, were not taken into account. Also, a non-response bias was also possible, as the patient who refused to participate in the study might have caused underestimation of the prevalence of psychiatric illness. So the main summary and conclusions are that we found high prevalence of depression, anxiety, stress, and dissatisfaction with appearance among the patients with acne. Implication of my study could be we need to evaluate the psychosocial issues among patients with acne vulgaris routinely, and the dermatologist must be well versed with these psychological consequences of acne. There is a need for close liaison between the dermatologist and the mental health professional to provide holistic care to patients with acne to improve the overall outcome of acne. Thank you all.
Thank you, Dr. Sahu, presenting well within time. Now it is open for questions.
You included only those patients who were on regular follow-up for about 6 months. Any specific reason for that?
So that we can take care of that. Those who are more ill, they want to come again and again to the OPD, and so that we can follow up the records, treatment records, how frequently they are adherent to the medications and all. So we took a cutoff of 6 months follow-up, because many patients, they also drop out after initial visit if they don't satisfied with the treatment. So we took 6 months follow-up after discussing with the dermatologist colleagues.
Then this BDD diagnosis, that is based solely on the responses to the questionnaire, or in those who screened positive, whether any psychiatrist did a clinical assessment and confirmed the diagnosis clinically as per, say, ICD-10 criteria or something like that?
No, sir, it was only limited to the questionnaire. So it was screened positive for BDD, but we did not do a thorough psychiatric evaluation for them.
Any other questions?
No, sir, none from here. So thank you.
Thank you.
Thank you, Dr. Sahu. Then we'll move on to the last topic, which is by Dr. Akhil Kesan. Early central glutamate and GABA changes with baclofen and acamprosate among patients with ADS, alcohol dependence syndrome, MR spectroscopy-based prospective study. Over to Dr. Akhil. You can start your presentation. Dr. Akhil, yeah.
Yes, sir.
Yes, my slides.
Sir, am I audible?
Yes.
Are my slides visible, sir?
Yes.
Yeah, they're visible.
Good afternoon. My study is early central glutamate and GABA changes with baclofen and acamprosate among patients with alcohol dependence syndrome, a magnetic resonance spectroscopy based prospective study. As it is known that craving is an established factor for relapse, as evidenced by many recent studies, such as those by Ludwig and Botlander et al. Anterior cingulate gyrus has an association in craving, and various brain models explain this, such as the interaction of mesocortical and mesolimbic circuits, that is the reward pathway, and also integrative model of brain and behavior that focuses on the role of salience in drug addiction, as shown by Goldstein et al. These are some of the studies which substantiate the role of anterior cingulate cortex in addiction, particularly craving. So what mediates this craving? The research in this regard has shown that glutamate and GABA play a central role in craving, as evidenced by some of the recent studies, such as by Browse and Mott et al. In fact, one of the articles published by Philip Witt mentioned that craving for alcohol is due to imbalance between neuroexcitatory amino acids, that is glutamate, and neuroinhibitory amino acid, that is GABA. Clinicians have been using anti-craving agent for alcohol use disorder, in which acamprosate is an established FDA-approved drug for alcohol dependence. There are many studies to support this finding. Few of them are shown here. Baclofen is a new drug for the treatment of alcohol dependence. Studies on its potential role as anti-craving agents are going on. So despite being an effective anti-craving agent, why are we looking beyond acamprosate and why baclofen? In a study done in 2020, in which 3 anti-craving drugs were compared, naltrexone, baclofen, and acamprosate, baclofen showed best tolerability in terms of liver function test, and least number of side effects were reported. Compliance, baclofen can be given as a single daily doses as an extended release formulation, but acamprosate has to be given as a thrice daily regimen. And also, if we calculate the cost, baclofen costs much less on a monthly basis as compared to acamprosate. So our need for the study is, both acamprosate and baclofen have been used widely as anti-craving agents for alcohol dependence. Their mechanism of action is yet to be clearly understood at molecular levels. To the best of our knowledge, no study to examine and compare changes in biological correlates by acamprosate and baclofen among patients with alcohol dependence syndrome has been conducted. So, aim of the study to investigate early changes of central glutamate and GABA levels at anterior cingulate cortex between acamprosate and baclofen among patients with alcohol dependence syndrome. Methodology, the study is a hospital-based prospective study done at CIP Ranchi after approval from Institute Ethical Committee. It is here purposive sampling technique with double-blind random allocation was done, in which 40 males with alcohol dependence and 20 age-matched healthy controls were taken. Inclusion criteria for cases, a diagnosis of alcohol dependence syndrome as per ICD-10, those aged between 18 and 50 years of age, severity of alcohol dependence questionnaire score greater than or equal to 15, clinical institute withdrawal assessment score greater than or equal to 15, and giving informed consent was selected for the study. Exclusion criteria for cases, any other comorbid substance dependence other than nicotine and caffeine, having any medical illness, having any other psychiatric illness, dementia or psychotic disorder, who are on any psychotropic medications in 2 weeks preceding the study, and those having any metallic implants or parts in the body. Similarly, inclusion criteria for healthy controls, male with age matched to cases and those who give written informed consent. And exclusion criteria were history of any psychiatric disorder, any major neurological or medical illness like head injury and epilepsy, and drug or any substance dependence except nicotine or caffeine use. The tools used were severity of alcohol dependence questionnaire, pan alcohol craving score, it is PACS, Clinical Institute of Withdrawal Assessment for Alcohol Scale, SIVA, and magnetic resonance spectroscopy. Data collection and procedure. Alcohol dependence syndrome patients were rated on SADQ, PACS, and SIVA at the time of admission. Patients fulfilling inclusion and exclusion criteria were enrolled for the study after detoxification, that is achieving a clinical institute withdrawal assessment score less than 10. Patient consent was taken and clinical data sheet and demographic details were filled, and double-blind random allocation was done into 2 groups. In group 1, baclofen up to a dose of 40 mg per day was given, and in group 2, acamprosate up to a dose of 1998 mg per day in those weighing greater than 60 kg and 1332 mg per day in those weighing less than 60 kg were given. Detoxification was done using lorazepam in both the groups. In day 4 after detoxification, baseline central glutamate and GABA levels were assessed using MR spectroscopy at anterior cingulate cortex area in the brain. In day 25 after detoxification, central glutamate and GABA levels were again assessed at anterior cingulate cortex in the brain, and SIVA packs were again administered. And finally, normality of the data was checked with QNES. Data was analyzed using SPSS version 25. Statistical test applied were chi-square, one-way ANOVA, Mann-Whitney U-test for descriptive statistics, repeat measure ANOVA for time effect of treatment between groups, and Spearman correlation to examine correlations. This is the consort diagram for our study, in which 100 patients were enrolled for the study, out of which 50 were excluded and 50 were randomized into 2 groups, group A baclofen and group B acamprosate, out of which 10 patients lost to follow-up, 5 in each group, and finally 40 patients were analyzed, 20 in each group. MRS data acquisition was done in a 3 Tesla scanner in a single voxel proton MRS sequence, in which voxel size was fixed for all patients at 30 into 30 into 30 millimeter cube at anterior cingulate cortex. This is the machine on which our study was done, and this is the area of interest, anterior cingulate cortex. The results: on comparison of socio-demographic and clinical variables, we found no significant difference between the group, except on the earlier age of onset of dependence in acamprosate, which would be an incidental finding. On comparison of glutamate and GABA between groups, we found no significant difference amongst the group at baseline and at 25 days after detoxification. On repeated measure ANOVA for PACS, is pan alcohol craving scale, we saw significant reduction in craving score in both the groups. On measuring estimated margin mean, we saw a decrease in craving score, which goes hand in hand in both the groups, as seen in figure 1. As seen in figure 2, we saw increase in glutamate levels in both the groups, which goes almost parallelly. And in figure 3, we saw almost comparable changes in GABA level in both the groups, in which there is increase in acamprosate over time and decrease in GABA level over time in baclofen group. On applying Spearman correlation in baclofen group, we saw positive correlation of duration of dependence and GABA baseline for with GABA at 25 days, and negative correlation of age of onset, severity of alcohol dependence questionnaire, pan alcohol craving scale, SIVA, and GABA baseline with GABA change. Similarly, on Spearman correlation in acamprosate group, we found positive correlation of SIVA baseline and negative correlation of glutamate baseline with glutamate change, and positive correlation of glutamate baseline and negative correlation of GABA baseline with GABA change. So discussion, coming on to the discussion, both acamprosate and baclofen had comparable change in craving, thereby indicating comparable anti-craving efficacy. In acamprosate patients, there was reduction in glutamate level and increase in GABA level as compared to the healthy control at anterior cingulate cortex. In baclofen patients, there was reduced GABA level as compared to the healthy controls at anterior cingulate cortex, as found in the earlier studies as well by Buripair et al. In 2018. In baclofen patients, there was reduced GABA level at 25 days after detoxification at anterior cingulate cortex as compared to the baseline levels. And in acamprosate patients, there was reduction in glutamate levels and increase in GABA levels as compared to the baseline levels 25 days after detoxification at anterior cingulate cortex. This finding was replicated in a study by Umhao et al. In 2010. Changes in GABA was negatively correlated with dependence severity, craving, and withdrawal. So we might hypothesize that baclofen would be more helpful in lower severity of dependence. Earlier studies by Krupitsky et al. In 93 claimed, so it can be hypothesized that baclofen could possibly improve anxiety through a rapid normalizing effect on GABA tone. In acamprosate, Clinical Institute withdrawal assessment baseline was positively correlated with glutamate change. This might indicate higher anti-craving effect of acamprosate on higher severity of dependence. This is consistent with earlier literature by Spenegal et al. So our study has shown comparable changes in glutamate at anterior cingulate cortex during early post-detoxification period, both for baclofen and acamprosate. Though comparable, two groups showed differential pattern of changes in GABA at anterior cingulate cortex. And effect of baclofen and acamprosate correlates differently with various clinical characteristics of alcohol dependence syndrome. Strength of the study, it was a double-blind randomized control study, and higher strength of MR spectroscopy was used to accurately detect the neurometabolite levels. Limitation of the study, the sample size was small. We included only males. Repeat measurement was limited to early post-detoxification period only, and only 40 mg of baclofen was administered. So future direction, studies with larger sample size and including both gender, longer follow-up for repeat MRS to examine late changes of central glutamate and GABA levels. Another group with higher doses of baclofen would be included in future studies for better understanding, and functional MRS with cues would be more insightful. Thank you.
Thank you very much. Dr. Akhil, thank you.
Thank
Good
you,
presentation. Now it's open for discussion.
Any specific reason for choosing 10 as the cutoff on a CYR? Because usually 8 is considered.
Sir, as per the reference I mentioned, it was mentioned that less than or equal to 10 Shiva score was given as mild degree of withdrawal. So 10 was considered here.
You have chosen the age group 18 to 50 years.
Yes, sir.
I did not find any rationale to do that because usually the clinical trials will take 18 to 60 years. In fact,
Yes.
when you are studying craving in alcoholism, it should be 60 years and above also. Can you explain why your inclusion criteria made only 18 to 50 and not 60 and above also, which is very important? And my second question is, let me complete my second question, then you can answer.
Yes, sir.
My second question is,
yes,
hello?
Sir. Yes, sir.
Shall
Yes.
I- second question.
Yes, sir. Yes, sir. Please. Sir.
My second question is, in allocating patients to the baclofen group or acomprosate group, what
sir.
methodology have you followed? You have taken allocation by lots, or you have explained to the patient? Because at one end in acomprosate, you are giving 3 tablets 3 times a day, that is 9 tablets a day, and 1958 milligrams of dose you said. And with baclofen, you are giving only 40 milligrams, patient takes only a single tablet. So have you explained to the patient that which group he wants to be allocated, or you have done it by lots and patients agreed? Can you answer these two questions?
Yes, sir. Sir, coming on to the first question, sir, we thought that we were measuring the neurometabolite level, GABA and glutamate. So we thought that with increasing age, it can be a confounding factor that those geriatric patients would show a differential expression of glutamate and GABA levels in their anterior cingulate cortex. So we kept the upper limit as 50 years. So to minimize that thing. And coming on to the second question, sir, this our study was randomized, double-blind randomized control trial. So neither the patient party nor the those doing the experiment were knowing in which group the patient was allocated. So we
I did not find. Go ahead. Please go ahead.
Yes, sir. We took their consent, written informed consent, and we took the consent of their guardians also that study is going on. We would like to involve them in studies, but we did not inform that which drug we are giving them, whether they are being allotted to acamprosate or baclofen.
No, in the first question, the answer is not very satisfactory. Why? Because you said 50 years. After 50 years, you said that the GABA and glutamate levels automatically naturally come down. That's why you did not include people above 50. If so, you are not supported with any articles in the review of literature. That after 50, the glutamate and in the ACC will come down naturally. So can you what I'm telling, can you clearly answer the first question? Thank you.
Yes, sir. Actually, we had one study by Mao et al. In which it was shown that the levels of glutamate increased, sorry, sir. The levels of glutamate is an excitatory amino acid. So with the changes in cortical areas, the levels of excitatory amino acid, predominantly the glutamate, increases in older age. And taking that into account, we took the upper age as 50 years.
So that was one of the reasons why you chose the criteria between 18 and 55.
Yes.
But anyway, thank you very much. I think we almost finished on time. I thank the organizers and also thank the judges sitting there, Dr. Shahul Amin, Dr. Shashi Roy, and all the speakers, Dr. Durva, Dr. Pavitra, Dr. Shobit Garg, Dr. Sahu, and Dr. Akhil. Thank you very much. All the best to you. Now it's over to the organizers. Now the session is over. Thank you.
Thank you so much. Sir, can you please send the judging sheet to me if possible?
Yes.
Yeah.
I'll message that to you. Sure.
Yeah, you can just reply to me on the WhatsApp.
Yes, sure.
Thank you.
Thank you.
Thank you so much. The session is over. Yes. 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 And Dr. Nilanjana, she's joined it online. And Dr. Surendra plus send us a recorded lecture. Yes, we have. Okay. He's here.
So two speakers.
Yeah, the speakers are here physical.
One is recorded.
Yes. Yes. जो उन्होंने दिया ना मैंने आपको So I would like to start the industry sponsored symposium by Alchem. on dignity and end of life care in people living with dementia, the Indo-UK dialogue. I would like to invite Dr. K. Krishnamurthy on stage to chair the session. So you can invite the speakers.
Start. Oh, thank you very much. Just one of the stalls, I seen a book, West Bengal, its contribution to Indian psychiatry. And we have here 4 speakers. I believe all of them are from West Bengal. So really, it's a great contribution by the West Bengal team. And we have a very interesting industry-sponsored symposium, Dignity and End-of-Life Care in People Living with Dementia, a Indo-UK dialogue. Before I start the session, I just will pose a question to the speakers as well as to the audience. Death is a punishment or death is a relief? Is it a positive event or a negative event? Because death could be relief from this wretched life, but we consider death as a punishment. In the Old Testament, it has been mentioned that God will punish those who have done sins with blindness, madness, and death. So there in the Testament, it is mentioned that death is a punishment. Death is a negative event. But now here are 4 speakers from West Bengal who have contributed a lot to the Indian psychiatry, who are going to discuss the dementia and end stage life. And then how in the pre-mortal period, that's what I'll put it in probably in neologism, in the pre-mortal period, what care should be taken about this? Now, I am told by the organizers, there are 4 speakers, 2 speakers are here, and 1 speaker will come online, and 1 speaker is a recorded lecture. Am I right? It's so. So, I think Debanjan Banerjee is here. May I request Debanjan Banerjee onto the dais and speak on dignity in dementia care, focus on human rights and autonomy. You have 15 minutes, sir. Please try to stick to the time so that the audience will get enlightened. Thank you.
Hello. Model, right. Thank you and good afternoon to all. Firstly, thank you, sir. It's a privilege to have you here, Pranam. And I should specially thank Dr. Gautam Da for, as usual, organizing and putting together the symposium, today. To start with, I think it's a very pertinent issue that Sir today brought about, that what is death? It is, as we look at it, now I work with older persons, and I will prefer to use the term older persons rather than senior citizens or aged, because that's the United Nations Convention. You are never too old. You age from the time that you are born. The thing is, as I focus my presentation today, I also represent the voice of International Psychogeriatric Association, because we have significantly worked in the field of human rights and end-of-life care. This is a very, very famous quote that I personally like from Russell. Age is like a ladder that takes you to a high, but to a very risky unknown. Now, what we are talking today about is about that risky unknown. And just because it is risky, it doesn't mean that it has to be quote unquote bad. We all know about the human rights movement that has been going on. India is a signatory to United Nations Human Rights, especially Convention for Persons Living with Disabilities. And fundamental human rights, when we talk about, older persons are no exception. So I'd like to start with that statement first. It's a very prominent statement from the United Nations that we will not enjoy security without development, and all human beings, all, irrespective of age, are born free and equal in dignity and rights. And here comes dignity in death as well. We all know about the problem statement of dementia. There is nothing to stress in it. We are, the world is rapidly graying. Whenever you open the WHO website, it's filled with statistics. Cases are doubling in 2 years, tripling in doubling in 20 years, tripling in 30 years down the line. So we do need to think about individuals living with dementia beyond acetylcholinesterase inhibitors, beyond memantine, beyond just the treatment. Of course, it's a very important part of treatment, but we also need to think that when a person gradually loses their capacity, their autonomy, how do we ensure dignity and rights in the person and take a hold when they live, but at the same time, probably their identity faces a crisis. What constitutes dignity in healthcare? Now, there are varying definitions of dignity. What dignity seems to me cannot be the same to many of you. To accept an universal definition that the UN has considered, the Royal College of Nursing defines, dignity is concerned with how people feel, think, and behave in relation to minded. These two words are very important: worth or value of themselves and others. Dignity doesn't depend on socioeconomic status. It doesn't depend on whether you are in a city or you are in an urban, rural population. It doesn't depend on how educated you are. It doesn't depend on your literary status. It doesn't depend on how much of healthcare access you have. It depends on what type of social recognition you enjoy by yourself and around your society. To treat someone with dignity is to treat them as being of worth in a way that is respectful of them as valued individuals. It is commonly considered with an acronym CARE: consent, autonomy, respect, and equality. Now, I request all of you to actually go through this very special issue of the American Journal of Geriatric Psychiatry. It has been made free to all with an open access, released end of last year. And it has contributions from 20 experts all across the world. I'm very fortunate enough to collaborate with the WPA section Old Age Chair, Dr. Carlos, the World Federation for Mental Health Secretary, Dr. Gabriel, and Dr. Kiran, who is the IPA chair. Now, we brought together a series of models based on dignity. Now, this is one of them. When you talk about basic human dignity, there are two aspects. One is self-respect, one is respect from others. And how can dignity be ensured? One, safety, privacy, equality, respect to a person's confidentiality and sexual health concerns, social visibility. If today, many times in COVID, we saw that when older persons are going out, they don't have basic amenities, they don't have house help. The legal enforcements are literally chasing them that you have to go back to home because of your age, you will fall sick due to COVID. Agree. But then this should be an informed decision. Even sometimes when I have spoken to my parents and grandparents about you shouldn't go out, you should stay confined in a room. Mind it, individuals living with dementia or many older persons, for them, meeting two people in a day, having a 15 minutes walk in their garden can be the only source of recreation and personal enjoyment. That's the source of dignity. If you rob them of that, that is when you are compromising dignity. And also, there is an intersection between ageism, dignity, and human rights. If you look at the figure, human rights crisis, which has been further elaborated or exacerbated by COVID, arises from our ageist tendencies, elder abuse, ingrained stigma towards aging, because we all equate death with terminal bad aging, and something which is quote unquote grain, and also neglect the positive dimensions of aging. So frailty and dependence also comes in. This is again one of our other works with relation to dignity in individuals living with dementia. And how does dignity in individuals living with dementia get compromised, or people with mental illness? One, ageism, loneliness and isolation, institutionalization, lack of policies. Even the Mental Health Care Act is insufficiently geared to the cause, increased dependence, lesser focus on functional recovery, neurocognitive disorders, inadequate healthcare inequalities, and social stigma and discrimination. Now that becomes a very, very important part. Now let me kind of set the forefront here before my other speakers, come to the board. Why do we discuss dignity in dementia? What is so special? Now imagine a spectrum where your cognitive capabilities, and that doesn't mean that the moment an individual is diagnosed with dementia, the person will not have capacity. It's a very, very wrong notion. It happens on a continuum. A person with mild dementia may also retain the capability to decide what's wrong for him or her. However, this happens on a day-to-day basis. It happens, many of you have watched Still Alice. So you know that, no matter how much your educational abilities are, it moves on a spectrum. There can be loneliness. There can be abuse, which can result from a burnout in the caregivers. There is impaired power hierarchy and dynamics inside the family. There is problem with communication, institutionalization, and finally, behavioral and psychological symptoms of dementia. This is really a wonderful read. It was a very good learning for me as well. Dignity Preserving Dementia Care, a meta-synthesis which brings together a lot of literature published recently. And this is the model that they propagate. Now, if you see, having compassion for the person, preserving the person's sense of self, and creating, an environment for the person becomes very important. Now, I am not going to touch too much of end of life care here, because that will be done subsequently by my other speakers. What I'm trying to do here is set the ground to understand why is dignity important in dementia care, and how can we preserve that as mental health clinicians, as general human beings. So, there are two aspects to it. One, helping their self-worth. Two, giving them visibility, not just by prescribing medicines and talking to their caregivers, but just think yourselves, how many of us really talk to an individual living with dementia one-to-one and tell, sir, ma'am, what exactly are you facing? If we assume that a person living with dementia will not be able to convey their needs, the mistake is right there. These are multiple documented studies, which are all freely available online, which talk about how dignity can be preserved in dementia. What I have done is kind of collated all the information and put together. Very basic things, many of them seem very generic, but these are the things which are often, at least in my career, as an early career geriatric psychiatrist, I have not seen. Sometimes I feel that the very term old age psychiatrist is also stigmatic. I'm not a psychiatrist of old age. I'm a psychiatrist of older persons. So introducing yourself, using preferred names, not using pronouns. Do not post signs, symptoms on internet. Sit beside while feeding the individual. Talk to them like you're talking to a person, not a patient or a thing. Honor their personal clothing and choices. Cover the catheter bag if they're catheterized. Keep the commode and toiletry clean and out of the way. Maintain clean living environments. Keep incontinence products out of sight. Address the person, not them. Remember that they also need privacy and confidentiality. And even though sometimes we like loving them, do not patronize. None of us like that. For nursing home residents, as many individuals living with dementia are institutionalized, optimal pain management, fostering independence in functioning, maintaining good nutrition, having a decent physical appearance and oral hygiene, which is extremely important, supervision for security, having an age-friendly environment design, training the staff to communicate, prevent isolation, encouraging group activities, restrict empirical and random use of psychotropics. Just because a person is agitated does not mean that the person needs an increase in their antipsychotic dose. And end-of-life care, which my other speakers will talk about. And finally, there is a concept called dignity therapy. Due to dearth of time, I'll not discuss it in detail, but dignity therapy actually helps to train physicians and individuals working in the field who can ensure dignity in dementia care. This is a beautiful article that was brought about by Alzheimer's Association, which discussed that the right to limit, refuse, or stop medical treatments, as Sir mentioned right in the beginning, is to how you perceive death. And ultimately, life belongs to whom? It belongs to you, it belongs to your parents because they have given birth to you, or it legally belongs to the government. It can be endlessly debated, but my viewpoint would be whatever it is, let us respect the person's choices, and weighing the pros and cons with a multidisciplinary team, let us take the decision not alone, but collectively based on patient's dignity. Again, this was a recent review of all the global evidence that we published in the Asian Journal of Psychiatry, in which we recommended not to. So when you are actually thinking about end-of-life care or physician-assisted suicide in people with dementia, which Dr. Gautam will be talking about, not to determine based on your own personal values or beliefs. It shouldn't be what I have done to my grandfather, so will be done to my patient. Not to provide selective information. There is no one size fits all. Not to disrespect the family's concern. Not to undertreat comorbid medical conditions, especially pain. To avoid both excessive patronization, not to violate medical code of ethics, not to bring in individual biases, perspectives, and opinions. When I was once going through the literature, I found out that in a specific tribal community of Africa, they often make the person lay down, bring the family members, and chant their favorite song while giving sips of water when the person is in terminal care. Now, this is how socio-cultural decisions affect the decision to end life or end of life care. Dementia with Dignity is a wonderful read by Judy Cornish, which I recommend all of you if you have time. And finally, let me welcome you all to the 2022 IPA International Congress. The website is currently up and ready in Lisbon, Portugal from 21st to 24th October. Thank you for your patience listening, and thank you, sir, for the opportunity.
Thank you very much, Devanjan Banerjee, for a very interesting and lucid presentation. Now, for the second speaker, virtual speaker. Organizers have not given me any guidelines whether questions should be asked of every member of speech, or should we have questions at the end of all the four? Yes, Gautam Sai, the expression. Yes. So whatever he says will be the order, and then we will have questions after all the four speakers. Now the next speaker will be End of Life Care in Neurocognitive Disorders, the Indian Caveats, by Dr. Nilanjan Paul. Is he here or is it virtual?
I'm virtual, sir.
Virtual. Thank you. Welcome, ma'am.
Good afternoon, Chairperson, sir, and the audience. Before I start, my sincere gratitude to the organizers of this conference for allowing me this opportunity to speak. I'm thankful to Gautam for organizing the symposium because it has been really an interesting read on an area which in spite of working with elderly for quite some years, frankly, I had not been aware of, or really we hadn't put our thoughts into it. And most of all, thank you, Devanjan, for choosing this topic. So I'll be speaking a little bit about end-of-life care in neurocognitive disorders, the Indian caveats. Frankly, it will not be really too informative. It would rather be some thoughts that I have found out while reading about it. It's really not information, and this is what should be done. It's not that. It's rather more of questions, and like questions that I have faced myself, as well as maybe is necessary for the professionals at large, maybe the government and the other health system to think of. Now, when we speak of end-of-life care in the Indian context, we are speaking mainly of palliative care, where we are withholding or withdrawing the life-sustaining treatment. There are related areas, concepts of euthanasia and physician.
Sorry, Nilanjana, make it full screen mode.
Oh, it is full screen.
No.
What's it?
Slideshow, yeah.
What is it not getting full screen?
No. Okay, then you can continue, sir. Chairperson, sir, please.
Can you see the slides?
Yeah, it is visible, but it is a slideshow.
That's correct. Slides are a little this thing, but then, madam, can you make yourself visible also?
Oh, I am visible. I mean, my camera is on. I can see myself.
Not to us anyway, because we are only seeing the slides.
That I cannot do. I mean, that is what they can do there, I guess.
And then you go one slide after another. All the 4 slides are seen. I mean, we may have to change your slide format probably. Okay, then go ahead.
Can you, I'm at the, I'm seeing the second slide, only a part. Shall I continue, sir?
Please do. Please continue.
Okay. And when we speak of end-of-life care or palliative care, we are aiming to improve the quality of life of both patients and families by responding to their pain and other distressing physical symptoms, as well as to provide the nursing care and psychosocial and spiritual support. So it actually goes beyond the biomedical model of health. And it is in fact an affirmative act of living with dignity, even whilst accepting that death is an inevitable part of life. So what is palliative care? It is both a philosophy of care and an organized, highly structured system for delivering care to persons with life-threatening or debilitating illnesses. The time frame actually extends from diagnosis till death, including the bereavement care for the family. It improves the quality of health care by alleviating physical and emotional suffering. It leads to better patient-physician communication and decision-making. And it assures a coordinated continuity of care across multiple healthcare settings, including the hospital, home, hospice, and long-term care. Essentially, it needs an interdisciplinary, multidimensional team of doctors, nurses, counselors, social workers, and volunteers. If we look back, palliative care is quite a recent development. Maybe it started 20 years back, about 20 years back, mainly in the context of cancer treatment, and with centers being set up in major cities. And currently there would be about 150 organizations or so providing.
Sorry, madam, 1 second. Your slides are not seen properly. We may have to change your slide format. You have to close and again open, because we are not able to see the first, second slide, third slide, fourth slide, etc. We are only seeing the first slide. So can you close it and open?
Yes,
And if
sir, I'll
possible,
do that.
yours-
I'll do that. I'll do that again. Because I'm seeing and I'm speaking from my slides only. I'll stop and go.
Oh, that's good. That's good. Please share the screen so you can show the slides in future.
Sorry for the.
She has to share the window. She has to share the window instead of sharing the slide. Then the slide will be visible.
Save the window. If we have a better solution here, you save the window. And then I don't
I'm
know.
going to share screen.
Save the window and then that's all. Huh?
Can you see this now?
We are seeing the previous one only. Now we are seeing, okay, the second slide is, okay then. Go ahead, whatever is best out of you. Huh?
I'll start share. I'll start the share slide. I mean, slideshow, right? Can you see it? You can see the second slide, right?
You can see. We are able to see it now. Okay, go ahead.
You can see that it's a ELC legislation.
Legislation in patients without
Right,
healthcare.
right. Okay.
Go ahead,
Yes.
because we're losing time. Huh?
Yes, sir. In 2018, for the first time, there was this Aruna Shanbok case where the Supreme Court recognized the possibility of legitimately withholding and withdrawing life-sustaining treatment when a patient loses healthcare decision-making capacity. Actually, this lady, she was a nurse and she was brutally assaulted in as early as 1973. And she was taken care of in a vegetative state by her colleagues in KEM Hospital, Mumbai. And it was only in 2011 that somebody, Pinky Virani, an activist and a journalist who thought of applying to the court for the first time that maybe this is not the life of dignity that a person deserves. But then this plea of euthanasia was again was turned down because her colleagues, her nursing staff said that we are taking care of her and who are you to decide that she should be killed in court. She ultimately died in 2015 of pneumonia, but it was in relation to this person's case that in 2018, the Supreme Court reaffirmed that there was a right, we have a right to die with dignity as a part of the right to live under the Constitution, and also gave legal recognition to advance directives where the patients may express their wishes for a time when they lack the capacity to make decisions. But this must occur according to the guidelines, court guidelines. Now, what are the challenges to end-of-life care in India in context of the neurocognitive disorders? We have a huge burden of dementia. And it makes it imperative to discuss about these issues.
The third slide has not come. Only the second slide has come. Please make a change. The third slide. I mean, all the slides are seen in sequence.
I'm unable to, because I'm seeing the third slide here. Can you see it now, sir?
Now I was saying, yeah.
Okay,
now
let it be like this. I'm not going to slideshow them.
Okay.
Okay. So there's a huge burden of dementia, and it is necessary to discuss about end-of-life care. On the other hand, the burden itself makes it a huge task and a huge public health problem. And there is also the issue of many dementia patients remaining undiagnosed and facing emotional and physical abuse, forget the dignity that they deserve. There is still no proper palliative care ecosystem for the elderly and the terminally ill, and it's a huge public health challenge. So the question many of the family members ask, and possibly we who care for elderly also ask, do terminal patients and the rapidly expanding cohort of elderly have a choice of dying beyond their lonely deaths in clinical ICUs. Considering the legislature also, our country has got various geographical, social, cultural, and medical backgrounds. It's a hugely heterogeneous country. So one model cannot fit all, as Dibanjan was saying. And possibly each state will need to develop its own policy that suits its needs and its social and cultural background. On the other hand, there is possibly a need for the central government to develop guidelines for general application and provide an umbrella of support. Dementia itself is a heterogeneous concept. Alzheimer's, frontotemporal dementia, they do not progress in the same way. They do not deteriorate in the same way. So the care services cannot be same for those with advanced dementia and those who are still cognitively aware. And the difficulty is, how does one organize a service delivery for such varying trajectories of disease? Now, we in the medical fraternity might also consider this admission that this patient can no longer be in a typical hospital care, but has to go to palliative care as an admission of failure of the medical system. It might be the loss of a business opportunity. And frankly, medical knowledge has not yet armed us with the skill to accurately estimate how long a patient is going to live. There are other sensitive issues like artificial nutrition. It's a difficult decision for both the doctors as well as the relatives, because there might be various reasons for poor feeding. It might be impaired swallowing, fear of choking, aspiration, or it might be the worst condition of progressive loss of learned behavior. And in any case, we have found that tube feeding may not increase survival rates. The terminal stages are also associated with rapid, irreversible deterioration on a day-to-day basis, with inability to eat, changes in breathing patterns, weight loss, lack of mobility, altered consciousness, incontinence, infections, bed sores. The persons are usually unable to communicate and are completely dependent on others for their day-to-day survival. Considering our limited financial and infrastructural health resources, this itself entails enormous logistic issues. And as Dibanjan was pointing out, all of us are not even psychiatrists, we are not really trained to deal with neurocognitive disorders at all places, because our concept of medical treatment is okay, only cholinesterase inhibitors, and that's it. This has happened to patients whom we see that who have been just advised a certain tablet, and that's all. They have neither the patient nor the family members have been informed about what to expect. So considering the multiple team that we need social workers, nurses, and other health staff. And frankly, we are at a loss, I guess, to decide on how to deal with the situation. Coming to the guardians, family members, many might be hoping for miracle cures. They have unrealistic expectations. We see this whenever we are dealing with patients with dementia in our clinics. They have the difficulty in accepting the inevitability of mortality. And another strange thing is that people might be more willing to care for their children with severe cognitive deficits in comparison to that in their parents. And of course, there is a legitimate concern about transferring the patient in end stage of life to an unfamiliar setting. And in many cases, the family members are not in a position to choose between adding a few months to the lives of their parents and whether they should be spending their last days close to their loved ones. And coming to the patients, they are rarely aware of their rights. Even the elderly persons would be looking to their sons or daughters or daughter-in-laws for their decisions. So forget those people who are having some amount of cognitive impairments. And finally, we come to the ethical issues. Who decides? Advanced directives are available in which a person with dementia can indicate his or her wish to refuse medical treatment, have been associated with reduced family stress and allows for easier decision making, but it is rare in practice. And the legal framework is too complicated and practically impossible to implement clinically as of now in the stage that it is present as of now. There's a condition of advanced care planning, where the person's preferences for care that they would like to receive when they may no longer be able to make such a decision or be able to make their wishes known. That is what is advanced care planning in dementia. But it is difficult to identify the time to plan, even as clinicians, as the capacity is lost with the disease progression gradually. And we might be apprehensive about discussing these issues about death and debility with the patients and relatives, concerned that it might be more traumatic to the patients and their relatives. Though, again, it has been found in a few qualitative studies that ACP soon after diagnosis has been found acceptable and thought to be a useful intervention. And the carers in any case found it helpful to know the patient's wishes in case they had to make a decision on behalf of the patient in future. Dying is inevitable, but a good death is not, especially in the circumstances of our country as of now. And can we hope to bring a change in this scenario? So I hope, actually, we in India and at least in Calcutta, frankly, I do not have so much of experience of dealing with this issue, but I hope my next speaker has been working in UK and we shall be able to get some better insight and knowledge as to the practical experience of end-of-life care in dementia care. And maybe sometime we shall be able to emulate and learn from the experience of our colleague from UK. Thank you very much, sir, for your participation and attention. And
thank you,
I'm so
Nilanjana.
sorry for the technical glitch. I'm really unable to understand why it happened.
But for the technical issues, the presentation has been very nice and then very comprehensive. And then I hope you will be available for the question answer session.
Yes,
which will
sir,
come
I will
after.
be. I am here, of course. This has
now
been a
we-
learning experience for me also, sir. Thank you, sir.
Thank you, ma'am. Thank you, Nilanjana. And then we invite the third speaker. I heard that it's a recorded, presentation, which is on end of life care in dementia management, perspectives from the United Kingdom. Ma'am, Dr. Sujay Mukherjee, now it's yours, platform is yours. Please go ahead.
Ladies and gentlemen, greetings from London. My name is Sujoy Mukherjee. I'm an old age psychiatrist practicing in West London NHS Trust. I'm grateful to my co-presenters for giving me an opportunity to talk with you about end-of-life care, some perspective from the UK. With respect to the chairperson, I would like to start my presentation. Yes, please go ahead. Is dementia a terminal illness? Are people dying from dementia or dying with dementia? We know dementia is a progressive degenerative condition of the brain, which results in people gradually getting worse and worse, both with their cognition and functioning, but at the advanced stage, it does affect various physical functions, particularly things like swallowing, not being able to eat enough, and generally make them frail and vulnerable. So though people may not die directly just because of dementia, it does make people susceptible to a number of other conditions. And also, as people with dementia are often older, they have multiple comorbidities, and they sometimes die of those causes. The other problem is that if a physical event happens in the course of dementia, sometimes it accelerates the progress. For example, if somebody has a fall and break their hip and end up having a major surgery, often end up in a post-operative delirium. And even if they recover, we see that there has been a significant decline in their cognition functioning, but also overall their physical abilities. When we look at the cause of death in dementia, the most common ones are either pneumonia, often secondary to aspiration, or it could be from vascular causes or other infections. So what is end-of-life care? End-of-life care aims to enable the person to die in the way that they would have wanted, giving priority to the things that matter most to them. It should make people comfortable while they are dying. It also supports the family and carers during the final stages as well as after the person has died. So it not only is a medical thing, it's about social support and providing comfort and emotional support as well. End-of-life care can last just a few days or weeks, but for many people, it may continue to months or even years. So it can be an ongoing process which might have started. And this is particularly true in case of dementia, because sometimes even people with advanced dementia, who almost you feel like may die any day, can actually continue living for quite some time. And this is particularly true now with advanced medicine, support of medicine, and also good nursing care. So how it relates to palliative care? So palliative care is for anyone diagnosed with a life-limiting condition, including dementia. It focuses on making a person's quality of life as good as possible by relieving discomfort or distress. And as you can see, that there are a lot of overlaps between palliative care and end-of-life care. But actually, originally, palliative care, the whole sort of specialty was developed in conditions like cancer or advanced lung or heart conditions where there is no prospect of the person surviving. But there are a lot of overlapping elements. There are some fundamental differences about palliative care or end-of-life care in patients with non-dementia, particularly because many of them can retain their mental abilities and can make decisions for themselves till the last moment. So how we plan a good end-of-life care when we start? This is a tricky question because we are often diagnosing people with dementia fairly early. So that means people are still reasonably able at that stage. And it's bad enough to tell somebody that you have got dementia. But on top of that, if you start talking about death and planning for death right at the moment, it can be quite overwhelming. Having said that, in Western countries, if you turn your television on, you can't miss all these advertisements about funeral services, constantly telling you how to plan your death. So it may not be as taboo a subject as we sometimes feel. But I think it has to be individualized. You have to judge when the person, your patient might be ready to talk about it. but it's better done early rather than late. And particularly emphasizing the point that dementia is a condition which eventually will take away their mental ability to make decisions for themselves. So it is important to make decisions around the death or planning of the death as much as making decision about their financial matters. Say, for example, making a will. So again, sort of supporting the individual to make their own planning, make their own decisions, what they want. Do they want to die in a hospital, or they would rather prefer dying in their own bed? Would they prefer dying in their own bed surrounded by their family rather than, with multiple sort of tubes coming out of their body in a hospital bed? That is where comes advanced care planning. People can say what they want or what they don't want. They might say, well, if I'm very, very ill, I don't want a lot of investigations. I don't want another CT scan, or I don't want myself to put in intensive care if there is no prospect of me surviving. But one problem, obviously, is when it comes down to life-sustaining treatment, unless you are very explicit, the duty still remains on the treating clinician to decide whether to obey what you have made in your advanced care planning or use their clinical judgment. And in UK, by law, you don't have to write up your advanced care planning. You might tell your GP or a health professional, it's recorded in your health record, but it is better to write it up, because otherwise, in a busy clinical setting, people may not know what you have said. And also, particularly if you said you want to refuse life-sustaining treatment or do not resuscitate, it has to be explicit and trying to elaborate whatever the circumstances might be. There's other options in the law of surrogate decision-making. So I can decide to give somebody what we call a lasting power of attorney about my care and welfare. So that person, often a child or a family member or a friend, becomes my attorney. When I lose capacity, that person has the ability to make any health-related decisions on my behalf. But again, if I want that person to make decisions around life-sustaining treatment, particularly refusal of life-sustaining treatment, I need to be explicit in that form. There's a special provision within the form to say whether I want to include that as well. What a good end-of-life care looks like. So end-of-life care should support the person to live as well as possible until they die. So once we know the person is dying, we need to make their life as comfortable as possible. So first, obviously, their physical needs, particularly pain relief. If there is any minor infection is causing them distress, constipation, and other physical symptoms need to be addressed. But at the same time, it's important to understand they don't need a lot of medication. So maybe some medications, unnecessary ones, can be taken off. You don't need to. They just need to be comfortable. Their emotional needs, including managing distress. That's where probably psychiatrists, we have a major role to manage behavior so that they are not distressed, they're not aggressive, upset, and also they're sleeping well. Those things are very important. Their relationship with others, including who they would and wouldn't like to be with them, their environmental needs, such as their surroundings and community. Obviously, in advanced dementia, the person may not be able to make those decisions at that time. And that's why this could be part of their advanced care planning as well. But also, you could take some effort to make the surrounding comfortable and familiar. In the UK, in our care homes, people in their rooms, often the rooms are decorated with all their memorabilia, the pictures, the objects from the family room, so that the environment is still familiar and loving objects are still around them. And finally, last but not the least, the cultural, spiritual, and religious beliefs and practices should be addressed to. And that's very important, because for some people, death has got very significant religious and spiritual significance, and that needs to be addressed as well. So how we contribute to a good death in dementia? We are part of a team. We are in the UK, various professionals involved, general practitioners, nurses, speech and language therapists, geriatrician, psychiatrists, psychologists, the family, priest, dietitian, care home staff. Everybody has a role. Now, the important bit is obviously to coordinate between all of them, and that is crucial. as long as they are communicating between each other and limiting sort of intervention at the minimum. But main focus is to make the person comfortable and safe. That is the best possible approach. We also need to talk about advanced care planning, as I have flagged up, well in advance, to make the person understand that death not necessarily need to be frightening. It can be, as comforting as possible, because it's inevitable. It will happen to all of us. And it's better to make those decisions while you still can. And then optimum management of behavioral distress, particularly in advanced dementia, unless the person becomes so frail that they can't do anything. Many of them in advanced dementia may develop what we call behavioral and psychological symptoms, and it can be very distressing for them and challenging for the caregivers. And managing them optimally is quite useful. And that's also a key role of psychiatrists, particularly psychiatrists who are trained in old age psychiatry, and supporting the family and carer through the anticipated grieving. As we say in dementia, the family almost start grieving way before the person dies, because it's not just the death, it's about losing the person because they change. And also eventually coming to terms with that person physically gone and supporting them through the process, preparing them along with the person who is living with dementia. This is also a challenge and our role as part of providing good care.
Thank you. Thank you, Dr. Sujay Mukherjee, for your...
So if we can live well, we can die well, and that's what we hope for. Thank you for...
Thank you very much. Thank you very much, Dr. Sujay. You have done a very good presentation. But then I would like to ask you, it's not about the subject, which department of the West London NHS Trust you're working? In the geriatric department, or is it in the terminal care department? I think he's gone off the line. Huh? I know, off the line. So that's fine. Thank you. May I invite the next speaker? None other than our just immediate past president, Dr. Gautam Saha. He's an apt man to speak on the topic which is allotted to him: physician-assisted death and end-of-life care in dementia, the Indian Psychiatric Society perspective. Yes, sir, Dr. Gautam Saha.
Full slide. Good afternoon, ladies and gentlemen. Respected Chairperson Dr. Krishnamurthy, my pranam to you, because it's an honor to speak under your chairmanship. And you know that, and at the initial stage, I'm really thankful to my co-presenters, Debanjan, Nilanjana, and Sujaida. See, all are very eminent academicians in this field, and you know that Debanjan is already have done the DM in geriatric medicine. So it is an added advantage of us in the presenting in this. He is the more motivator of this presentation. And I must thank to, because you know that it is an industrial sponsored program. So thanks to ALChem for supporting this program, and also Indian Psychiatric Society for giving us the opportunity to presenting from this dais. Today, I want to talk on physician-assisted suicide in patients with dementia. It is really very, you may say, controversial. Some conflicts are there. In fact, when we become physician, we are just to know that we are meant for giving life, not taking life. That was our idea behind that. That we doctors are always, we can give life to a person, of a dying person, or a person is born to, we will help, but for dying, we are not meant for that. But sometimes it is controversial. We have to do so, and why, and when, and where it is legally valid, where it is not. Today, my topic I'll discuss, try to enumerate all these things today. You know that physician-assisted suicide, it may be active or passive. What does it mean? I mean that active, if I give some medications parentally, but what maybe I want to actually, as patient wants to die, I assist him like this. Or passive, I just withdraw the treatment. And you know that especially one school of thought is that they prefer, it cannot be a suicide. It is a physician assistant dying. Suicide generally means whatever the method was taken, it is taken by the patient itself, or the man or woman himself or herself. It cannot be done by the help of other person, but here physician is the other person. Yes, it is legal in some countries like Canada, Belgium, Netherlands, and other countries you have seen, the Switzerland, parts of USA, not full US, and Australia, Victoria. And there are subjects to conditions like terminal illness. You cannot, man, just I want to die. It cannot be done. It cannot be said that it is a physician assistant suicide. It's some cause should be behind that, like terminal illness. And it can be, whenever you give your consent, you should have some sound mind and voluntary, repeated will and independent assessment should be done. And there are lots of ifs and buts like religio, politico, socio, moral issues. If you see the history, there are lots of arguments on this, why we should do this. Definitely they in favor of, we can say they should respect the patient's autonomy. If there is so much of pain, as it was discussed by Devanjan also, and definitely after that, Nilanjana and Sujayada also, that dignity is one of the most important. Yes, you cannot birth, it cannot in your hand. But when you're living with dignity, it is on you. But die with dignity, it is on you as well as the others. So you can decide whether you will die with dignity or not. That should be a right of any person. That is the main thing of physician-assisted suicide. Equal treatment of the terminally ill patients, decreasing suffering for the life support patient. Yes, it will help, definitely. There is lots of life support. There is no positive hope. Only suffering till his death. Then one should get this chance that, no, I don't want to live with such a pain, with such conditions. Compassion, personal liberty rights, and definitely more important is transparency. Everything should be documented, whether really patient wants to die or the pain what was expressed by him or her, or what I say is real. And not only that, whenever he took this decision, whether he was in a sound mind, that is also important. Whether he has got that capacity or not. Otherwise, there is some legal problems there, definitely. Sometimes, why suicide? They are telling this is killing oneself is equated with suicide. By himself or by someone others. It cannot be, in my. But reasoning says, yes, it is done by his or her will only. So this is also fallacy and considered to be a messy, painful, unduly immoral act. As I said before, initially, that as a doctor, how can we assist this? This is a belief system. More emotions is there rather than any science or anything. If somebody is suffering till his death, if we reduce his suffering, that is also a point we should take care. Religious and social connotation, as I mentioned before, lay people, especially those in terminal illness or has a loss of capacity, or might not even be able to end their lives. That is why assistance is necessary. And assistance of a medically trained person to have a timely, painless, dignified death. Again, I repeat it, timely, painless, and dignified death. It is just in time we should do it. We should do it for his dignity, maintaining his or her dignity. And it is most important. And that is why it is so controversial and legally also, because if we can do this as a physician, if we do this, next day his relative, his son or daughter came to us, and why you should kill my dad or. So there should be legal validation is very important. And before legal validation, you have to consider also science, whether it is really necessary or not. And medical science, and it is not like mathematics, 2 + 2 = 4. You have to consider the emotion. You have to consider his medical conditions. You have to consider whether it is legally valid or not. Everything should be under the same umbrella. You know, though, that there are the countries where I mentioned that Australia Right of Terminally Ill Act in 1995, and the Voluntary Assisted Dying Act was 2017, like Belgium 2002, Canada 2016, Colombia 2014, Netherlands 2002, New Zealand upcoming agenda is in 2020, US, Oregon, Washington. In fact, they have a study I'll mention later on. Vermont, California, Colorado. There are lots of countries, they allowed this. And lots of countries in between, whether they will decide or not, still they are working on that. Oregon report says, if you see the graph properly, that Washington and Oregon has after the 2010, it is a pickup. I mean, the physician assistant suicide is much more common right now. And if you see the support in this method is mostly seen in the Belgium, followed by France. And why they are doing this, what is the cause behind this? If you see, more than 75%, almost 77% is due to cancer patients. And regarding the age, if you see, it is seen that most of the patient is above 65%, 65 years of age. And the cause mainly the pain. You know, the cancer patients especially have a very excruciating pain, intolerable pain, anxiety, extreme air hunger, ventilation, advanced cognitive disorder, and common reasons for physician assisted suicide. In fact, it also depends, in my knowledge, I always think cancer patient, maybe it can decrease, because as far as upcoming treatment of the cancer patients also now improving. There are lots of hope now growing in cancer patients also. So it is not that maybe this painful situation persists not for a long time. So whenever you take the decision, type of cancer is also very important nowadays. If it is treatable, if it is curable, then definitely taking a decision or accepting the decision of physician assisted suicide is definitely differ in near future also. 78% who opted the assisted death are over 65, as I mentioned. And most are diagnosed with some form of cancer. And 0.3% had a cognitive disorders. You know, here is also the question. If the cognitive disorder is that level, whether he is not taking the decision, especially in dementia patient, then it cannot be accepted. It is only if there is previously he gave the decision, and now in Mental Health Care Act 2017 in India also, they can give the opinion before that I cannot take any medications or any help during my illness. And you know that why they wanted to choose assisted death, most important are loss of ability and autonomy. Most of the, almost more than 90%, and more than 80% loss of ability to enjoy and live life with the families. More than 75% loss of independence of thoughts and action, and 70% is loss of dignity. So regarding dementia, there are lots of questions. Would you want to live with a loss of autonomy or dignity? We have to ask all these questions. What defines your independence? What independence he or she wants? Do you want to continue living without sensing life at the will of the law or your family? If you get detected with dementia, you know that it is progressive. Will it change your advance directives? And life with continued life support and without memories, is that living to you? In fact, all dementia, as Sujayda also mentioned, Dr. Sujay Mukherjee, that all dementia prognosis is not the same. Sometimes we want that our parents should be there, maybe like child, maybe incontinence of urine and stool, but they should be there if they don't have any problem like this. And sometimes patients also not complaining like this. I have seen at my home also. So it is a blessing like us. So we should not consider those patients for the physician assisted suicide. And they are also not ready to ask. If they have diagnosed earlier that they have a dementia, and before that they have taken this decision, there is a cue also. What to do? All dementia are not very bad in that sense. I mean, they are not suffering. You cannot say they suffered like this. So you have to consider that condition also. Why physician assistants in dementia? Many people with dementia whose suffering cannot be reduced with optimal medical treatment and social care. That's true. For those patients, you can consider, definitely you should consider. Physical symptoms take a toll in the advanced cases. Yes, there are lots of patients, there are lots of physical symptoms, which is really, you cannot see those patients with this suffering. Not even then, there is a really problem for us without any hope in future that it will be corrected. Invasive ways of life support, painful helplessness, witness to their suffering, loss of intellectual capabilities, and gradual dependence. Personal beliefs, social context, values, self-image might take the future prospect of humility, and also the many decides on advanced directives to end up their life while still in capacity. So what are the caveats? Who takes the ultimate call? Who? In fact, there are some legal opinion regarding this, whether the patient, whether their relative, whether the physician. Actually, as the advanced directive in new MCA 2017, advanced directive, you can write that before. And sometimes it is actually in India, I am coming on this Indian status. What is the status right now? But the world where it is valid, there definitely the patient can take decision before. Only patient can take decision that whether they will take physician assisted suicide or not. Role of the physicians, whether it is active or passive. Legislation cannot be blanket for the dementia. As Dr. Sujay Mukherjee mentioned before also, that they can express it, not in writing also, can verbally. He mentioned that. But he suggested that it should be in writing. Capacity and autonomy, accuracy of the diagnosis, time to reach severity, and continuum of the cognitive decline. When does capacity end? This is also important. I mentioned how long they can, if person is diagnosed as dementia, whether his cognitive function is really that level that they can give this consent. And moral, ethical, religious questions are there. And you have to be very legally sound. Otherwise, you know that India, country like India, there are, even in the other countries also, the property litigation is very important. Maybe they can ask after this physician assistant. In India, there is no scope in India. That is why there are so much of controversies, and government also thinking of like that. There are lots of, in fact, in some cases, as Nilanjana mentioned, I'm coming after that. Before that, this is the actually, that early diagnosis to promote self-determination, and it is important because flexible legislative option for physician assistant suicide in dementia. What you need? You need a thorough evaluation, independent assessment for his capacity, sufficient understanding of the illness, whether really you can give this consent for this illness, assessment of the competence and the context, whether there is a advanced directives or not, if it is proper, voluntary choice is most important, and substantial autonomy and respecting personal choices. You have to consider all these points whenever you take these decisions. This is another study, that what it shows that 21.6% physician assistant suicide consultations are perceived to be difficult, if it is not more. Difficulties are not related to the complexity, but rather patient clinical factors. And age, diagnosis of CVA, less comfort of the physician, age-related health problems, existential issues are equally important to take a decision. What is the Indian scenario? As Nilanjana mentioned these cases, Oruna case, I think I'm not going in the detail, that ultimately, that Supreme Court said that right to die with dignity for this case in terminally ill patients is a fundamental right. In 2018, the Supreme Court of India declared through a 5-judge constitution bench that if strict guidelines are followed, the government would honor the living wills, allowing consenting the patients to be passively euthanized if the patient suffer from a terminal illness or is in a vegetative state. A decision has to be taken to discontinue the life support either by parents or the spouse or other close relatives, or in absence of any of them, such a decision can be taken even by a person or a body of person acting as the next friend. It can also be taken by doctors attending the patients. However, the decision should be taken bona fide in the best interest of the patient. In fact, nowadays it was done the long time a patient is under the ventilator. Then after a long time, there is no hope. Physician asks to the relatives whether we will continue it or not. In fact, in COVID period, it was a very difficult phase faced by some ethical issues by the physicians. They know that those patients, those are in ventilator, they are not going to survive, but they have to wait. But they also know that there are patients are in the waiting list. If they got the ventilator support, they will survive. There is so ethical issues, and it increases the mental problems in the physicians also. There is evidence with studies are there. Such a decision requires presence of two witnesses and the countersigned by the first-class judicial magistrate and should also be approved by a medical board, said by the hospital. So it can be done. So what Mental Health Care Act 2017 said? It says that, you know, that now advanced directives are included, nominated representatives are there, issues of social taboo, cultural beliefs, advanced stages at presentation, lack of conformity between the MHCA 2017 and the Supreme Court Bharti documents. There are some issues. I hope that in future we'll discuss it, definitely in the government level, and IPS can take a great role on this. Specifies on advanced directives for the end of life decision and physician-assisted suicide in dementia is not very clear, I can say. And all the more reasons for the clear legislation and to preserve dignified death and right to die. So there are also counter arguments, you know, that risk of abuse is there also. Abuses are anyway possibly even in the case of prohibition in context of legal actions at the end of the life. Right to live, yes. Right to dignified death rather than a breath for others. This is our answer in favor of pass. Does the state own the lives and suffering of the people? All advanced cases of dementia do not have a worse ending, which I mentioned earlier also. And this is true that most of the cases it is, and at least with the present treatment available, right of the autonomy and dignity need to be respected even at death. Do not harm as a doctor. Help in reducing pain, suffering in invasive procedures in a guided way. So, end of life decision, a person living with a dementia has the legal and human right to limit, refuse, or stop the medical treatment. Advance directive regarding the end of life decisions need to be followed. Because it is important. Nowadays, advanced directives is available in our country. I mean, it is active in our country by new Mental Health Care Act. Physician-assisted suicide by withdrawal of aggressive treatment cannot be termed as euthanasia. Palliative care needs to be dignified and tailored to a person's pain and suffering. That means palliative care should be there, but as well as we can think of physician-assisted suicide. And what is said, what it is, euthanasia is an active role, part of the physician-assistant, you can say. Staying true to the person's wishes, core beliefs, and choices, weighing pros and cons, continued life support in advanced dementia based on the patient's dignity and respect. The main thing is whenever we're going to consider the physician-assisted suicide, it is for the patient, by the patient only. Because we want to reduce the pain, the symptoms, we want to maintain the dignity of the patients only. So, but that should be under the legal validation. If the physicians comes to this, one of the important studies which again showed that if the physician comes to the conclusion that the suicide request of the patient is a sufficiently autonomous, well considered, stable decision, measures to prevent helping the patient from carrying out the suicide can hardly be justified ethically or legally in the light of the person's dignity as a human. So dignity is the most important part. And coming to my end of the presentation, you know that this person, Stephen Hawking, who said, I think those who have a terminal illness and are a great pain should have the right to choose to end of their own life. And those who help them in that should be free from prosecution. Thank you. Thank you so much for the patient here.
Thank you, Gautam Sahab, for the very beautiful presentation. And then we have overshot the time, more than 15 minutes. But then there should be some questions and answers for a scientific discussion. I can permit about 4 or 5 questions. May I request both the speakers, Debanjan and Gautam Sahab sir, to please come and occupy their seats. Hope Nilanjana will be available for online answering. Are you, madam?
Yes,
No?
yes, sir, I am here. Hello.
Okay.
Yes, sir, I am here.
Thank you very much. So we have 3 speakers who will be answering your questions. Please be brief, identify yourself and ask questions. If you have a clarification, be brief. Thank you. I can permit 4 or 5 questions. Any questions? Debanjan, is dignity which you presented, is it closely related to quality of life?
Yeah, thanks, sir. I think, yes. So there have been studies, which show that personal dignity is actually very closely related to well-being and quality of life. I just take the opportunity to tell one statement here, not only as a clinician, but as an individual who has taken care of my own grandfather for almost 8 years, who suffered from Alzheimer's. Of course, that time I was not a qualified psychiatrist. But then I realized that there are a lot of times, lot of pitfalls when we impose our choice on the individual, which in fact impairs their quality of life and how they want to be treated. So just as a personal experience as well.
Thank you. Any more questions? Nilanjana, madam, you mentioned Arun Schambach's case. Arun Schambach case, it is not a geriatric case at all. It's at a young age, she was raped, brutally assaulted. I don't know why, she has, of course, there's no evidence that she developed a neurocognitive disorder or a case of so it's sort of human rights violation, that's something like that. And then please clarify why you have mentioned Arun Schambach's case.
This was actually, she was in a vegetative state, that is what, for about 37 years, till this case came up. She was not able to eat, speak, or, the usual expressing that we understand as evidence of having intact cognitive functions. So that is why this is a landmark decision regarding patients who are unable to speak out or unable to decide or express their opinions regarding their care. So that is why this case has been considered to be like, and that was the first time that euthanasia was considered in the Indian court. But of course, that was not supported by the government, by the Supreme Court. But then it was in relation to her suffering that this consideration that we have a right to die and that it is possible to remove life supporting life support in cases where there is no hope. That was the support, like the end of life or like palliative care was sort of corroborated by the Supreme Court after 2018 in relation to Aruna Sharma. She died, I think, when she was 40. She survived for about 40 years. She was, yeah. So
she died 2 years back.
2015. She died of pneumonia, but she survived in that condition for 42 years. So maybe she was
justified in including that.
That's no, thank you. She wasn't really having, and she wasn't of the elderly age group, but she was certainly not in a position to express herself that way. Cognitive impairment was certainly there.
Thank
you. So
she had hypoxia.
Yeah. So I mean, in total agreement with Dr. Nilanjana, I think you're very correct in telling, sir, that it has no bearing whatsoever with dementia and end of life. But when we actually go back to history of euthanasia, that is probably the only case which kind of brought a landmark decision. So all three of us kind of alluded to it because only when we are talking of care, definitely it is, directly not linked to a neurocognitive disorder.
Gautam sir, I'll tell you, the physician-assisted suicide and physician-assisted dying are two different things.
Yes.
Physician-assisted suicide is the Jack Kowalski model, where where the patient is, in active role and physician is in a passive. Whereas physician-assisted dying, doctor is in an active role and patient is in a passive. And so I think both are different. No.
No, sir. No, sir. What my conception goes, actually, one terminology exists: physician-assisted suicide. I told that it should be changed as if, because one school believe it should be physician-assistant dying.
That's very intelligent way of telling
Because
that it should be two different
because
things.
two different things. If it is active, what you said, because physician-assisted suicide has two parts. One is active, one is suicide. Active means we give some medications, or physicians have an active role. That can you say, according to, I do agree, that is physician-assistant dying rather than physician-assistant suicide. But all the same, actually here, the most important is patient wants this because of his pain, sufferings, or dignity, whatever you say. Patient wants this. He wants to die or she wants to die, or somebody wants in favor of patient that she does not want to continue this. But the physician is just part of it. No way physician is an active part of it. He was directed to withdraw or directed to give some medications as per, because the decision is not taken by the physician by anyone.
It's in the interest of the patient, taken by the patient.
Patient taken by the patient.
Thank you very much. And then can I take, or can all the audience here take, that all three of you recommend that there should be a thanatology department in every medical institution, where death, counseling about death for the terminal patients.
Yeah, I think, sir, this is like, it's a brilliant idea. In fact, when I mentioned about that paper where we reviewed the recommendations and especially the Oregon law. So one of the things that they mentioned is we as physicians, we are afraid to talk about death because of our own uncomfortable feeling. Many times when we disclose diagnosis of HIV or disclose diagnosis of cancer, many times the family is already comfortable with, but we delay it because of our own discomfort. So discussing, and I think that also goes with the classic Death and Dying by Ross, that it's, having a thanatology department or a discussion will also make the grieving process easier. So, it's loss of an identity even when the person is alive. So it is still grieving the person. And when it starts early, it will not only help the doctor and the physician, it will also help the family to grieve the loss and give a closure to the physician as well.
Absolutely. We know the importance of breaking the bad news in the corona period. It is like that. It should be methodical and scientific. Then definitely the outcome will be much better.
Thank you very much. And then we have had three erudite learned presentations from three Bengali people, the contribution of West Bengal to psychiatry and Indian science. But then before I conclude, let me tell you, I also have a small Bengali connection. I was born in Bengal. So in that way, I have also small West Bengal contribution. Thank you very much, my friends, for your patient presence and listening and participation. And then I return the microphone back to the organizers for further proceedings. Thank you.
I would like to invite the president of ALCHEM, Dr. Yogesh Kaushal, to present our speakers with the mementos.
persons are online.
I'm there virtually, sir. Thank you so much for being there.
So we have to, chairperson has to felicitate the speaker, the certificate. Dr. Debanji. So online hai? Zoom chat. So I would like to start the session by inviting our chairperson, Dr. K.K. Mishra, on the stage and Dr. Bidyadhar Vatwe.
Click.
Good afternoon, everybody. And just sorry for the delay for 10 minutes. And we have those who have joined online. And we're going to start the talk by Dr. Subodh Dave, who is actually being one of us doing his initial studies from JJ Medical College, Mumbai. Now he is the Vice Chair of Upper Institute of Health Sciences, and he's the Director of UG Education at Duxbury. And today he's speaking to us in advances in psychiatry education. We have already also a lot of time back also have listened to him in advance in psychiatry education. And I think today's presidential address was also how much we have to improve in the psychiatric education, because that is our main focus, both at the level of undergraduate and the postgraduate, because those are the areas which has been overlooked over the years, and those are the crossroad areas. So without wasting much time, I'll request Dr. Subodh to start his talk.
Thank you very much. Well, it's a great privilege to be here with Dr. Professor Watwe, teacher, and you, Dr. Sagar. So lovely to be here. I first want to show this is an old picture of Grant Medical College, which is where I trained, and Ananta is here as well, who trained with me in Grant Medical College. It's one of the oldest medical schools in Asia. And I go back here because I think we worked very hard when we trained there. And I think one of the things that we learned very early on was that you need to do the best for your patients. We had literally hundreds of patients coming in every week. But one of the things that I learned only after I went to the UK was that sometimes you can forget the link between how science influences the outcomes for your patients. So to give you an example, patients would queue up from 8 in the morning. And while I thought about treating them and thinking of the best treatment for them, not once did I think that, well, how do I make their life better while they're waiting those 6 hours? So we didn't really even think of setting up a register system or anything like that. And so for the thrust of my talk today is really about how can we make sure that education and training of psychiatrists actually improves the quality of care for patients. And an example of this is what we've been doing in Nottingham, where we have tried to involve our patients so that we hear from them and then what helps them. And so we run a large program of expert patient educators, and more about this a bit later in my talk. And now, of course, as the Dean of the Royal College of Psychiatrists, my main priority is to bring the educational and clinical worlds together and to see how the education and training of not just of psychiatrists in training, but also of the entire workforce is really able to improve outcomes for patients. So, psychiatry is not a very old science. The very first textbook of psychiatry came in 1812. And, I think the next textbook appeared in 1867 when William Hammond was appointed as professor of nervous mental diseases in Bellevue. Some of you might have visited that in New York. A friend of mine used to work there. This polyclinic that was set up as the first psychiatric polyclinic has now transformed into this hospital, the Manhattan Psychiatric Center, which is where the first psychiatric inpatient unit was set up. And most of us will remember Adolf Meyer, who really talked about the links between the psychological and the biological world. And to me, I think that is what makes us psychiatrists. I think that we as scientists have always thought about what links the psychological and the social and the biological world. And then we explored that and we studied that as scientists. And I think it really is important that our science, our training and our education reflects that, which I have to say sometimes has not always been the case. And so as a medical educator, I have followed the history of medical education. And I think, to be honest, I don't think that medical education has changed significantly since the first medical school was set up by Flexner in 1910. So the very first medical school, we had they still follow the same preclinical followed by clinical years. And it's very much kind of centered around the biomedical model. And so my talk is really today is going to be about what are the current challenges and how do we face these challenges And how do we probably start challenging the medical school model, which has been very much around, well, we'll teach you the biomedical sciences and then get you to learn some clinical work, and then we'll see how you apply it. And so for me, I think these are the main challenges. I'm going to focus on health inequalities first. And the reason for that is because if you want to test how good your training is, what better way to test it than to test it against the weakest link in the system? So if your health, if your training offer, if your education offer is not able to deliver care for the most vulnerable people in the society, then obviously something is missing in that education and training. And I feel that that's where I feel a lot of our education and training has failed to deliver, because we continue to see that large sections of our population don't get the health outcomes that they should get. And yet we don't hold our training systems accountable for that. And I want more from our training of psychiatrists. Our psychiatrist education should be measured against how it produces improvements for the most vulnerable sections of our population. And so that's the challenge we have. And why is that important? Because we know that the more unequal the outcomes are, the poorer the outcomes are for people on a range of issues, not just their mental health, but also on their physical health. They're likely to die younger. They're likely to experience more accidents. They're more likely to have problems with their children, and so on and so forth. They're more likely to end up with the criminal justice system. So actually trying to deliver better mental health care and a more equal health care is better for all of us. And it's that last phrase of mine is quite important, because it is better for all of us, because quite often we think that if somebody's poor, then they are the ones who pay the price of being poor, and they'll have poorer health outcomes. What we don't realize is that if you live in a society where there are a lot of people who are living in poverty, and when you might be a millionaire or a billionaire in Bombay or in Kensington in London, your health outcomes will be poorer compared to matched billionaires in other societies. And so I think that is quite an important fact to remember. And I think this slide is quite important from that point of view, that unequal societies are bad for all of us, for every person living in that society. And an illustration of this is that irrespective of which country you look at, we know that people with severe mental illness die about 2 decades younger. Now, this is something that is consistent across several studies. It's been known for about 3 decades, and yet we have not been able to make a dent in that entire mortality gap. Our patients continue to die younger, and I think that is something of a scandal. We should really be getting more upset about it. We should be asking more of our health systems and of our training to see why are we not able to narrow that gap. Similarly, we've known this finding for at least 2 decades now. This finding is quite robust. We know that if you have children who suffered more than 4 adverse childhood experiences, their outcomes on a range of conditions are far poorer, whether it's 10 times the risk of substance misuse, 10 times the risk of self-harm and suicide, 4 times the risk of depression, 4 times the risk of cancers, twice the risk of cardiovascular illnesses. So the list goes on. And I think despite that, Ananta, you spoke earlier about this, I think there is very little investment either in the education of early life disadvantage or indeed in its management and in clinical practice. So I think I'm quite committed that for us at the Royal College of Psychiatrists, our curriculum will really focus on this so that not just for the training of child psychiatrists, which is where you'd think that this is important. I think it's important for every psychiatrist. It doesn't matter the training to be old age psychiatrists. These factors remain relevant throughout all the age groups. And I think there should be a mandatory part of psychiatric curricula and indeed medical curricula across the world. Other challenge we're facing is that we are all growing older, and I think that's true of populations across the world. And as you grow old, you experience more physical and mental health problems. And this is certainly true in India, where the projected increase is perhaps even more dramatic than in many other nations in the world, because over the next few years, we will see almost an increase by 324 million. So more than 20% of the population will hit that mark, and that will have a significant impact on what the training of psychiatrists is needed. Another statistic here, I think we know that mental health policy is absent in a lot of the countries. In many of the countries, people are not taught about policy and politics or influencing policy is not really part of the standardized curriculum. And I think this has real problems. I think I've been involved in setting up the postgraduate training program in Zambia. And unless you actually train people to influence policy and train people to speak up, I think you find that psychiatry gets left behind. I think we heard earlier today about how there's very little investment in mental health services across the world. And part of that has been because it's not been thought of an important part of psychiatric training to ensure that people actually speak up and are able to influence policy. So I think that's something that we need to be thinking about. And I think when you consider that 25% of the countries, there's no legal protection at all for the civil rights of mentally ill people, that's a shocking statistic. I think resource inequalities have been talked about throughout this conference. I think we all know that. I think the resource inequality is even more stark in lower and middle income countries, where the percentage amount of the overall GDP for mental health care is often quite paltry. So I think, and the training is restricted to some very specialized urban units, and services are delivered in large urban centers. So what do we need of our training? I think we need to recognize that psychiatric illness doesn't occur in isolation. In fact, if you look at this slide, you recognize that most of mental illness happens is comorbid with either substance misuse or with other physical health conditions. And this has a role to play in the training of psychiatrists. So I think it's a valid question for psychiatrists to ask that what should you be able to treat things like diabetes? Should you be able to treat basic cardiovascular illnesses like hypertension? Should you be able to manage smoking and substance misuse? Or should that be left to specialists, and should your role be referring alone? Now, I'm sure people have different views, but what I can tell you is that in most curricula in the world right now, we train psychiatrists as if they are likely to see people only with pure mental illness, and they will never or hardly ever come across anyone with comorbid substance misuse or comorbid physical health conditions. And I think that's a real challenge. I think, and it creates problems in the management of our patients, and as a result, our patients actually die younger. I personally think that we need to address this quite rapidly. Workforce capacity is a real issue, and I think I'll quote some data from India. We know that globally there's a shortage of about 1 million in the mental health workforce. Obviously, the shortage is far more pronounced in the lower and middle income countries like India, where we know that the ratio of psychiatrists to population is quite low. Now, it's better here than some of the African countries, and I think you can imagine that there are some countries where there is no psychiatrist at all. And so we need to be thinking in terms of not just the training of the psychiatrists, but the overall workforce. Again, 50% of the lower and middle income countries, there is no occupational therapist or any other allied healthcare professional in psychiatry. And that poses a real challenge where in a multidisciplinary field like psychiatry. This is another big issue, I think, for us is a big challenge. I think medical education is broadly taught in very pathological models. So we learn about symptoms, and then we try and figure out what is wrong with the individual organ. So you investigate the liver, you palpate the liver, and then you do an assessment, and you come up with a diagnosis, and then you come up with a treatment plan to fix the liver. And then that's the model that we've tried to apply to the rest of medicine. I don't think it works particularly well with the liver, and it certainly doesn't work very well with psychiatric disorders like schizophrenia or depression, where we know that the community plays psychosocial practice play a significant role in the genesis of psychiatric disorders. So we heard earlier today about how social determinants play a significant role. And yet, I think if you look at medical regulation, and this is true of the UK and US and everywhere else, when we talk about what is good medical practice, it's very much about the doctor-patient relationship. It's very much about how, as a doctor, you've treated the individual organ or how you've treated the individual patient. There is literally no reference to what has been your role as a doctor in managing the care of the community that you're practicing in. And then what is your role in managing, and how responsible are you for the care of the communities that you practice in? So we are fixing that in our good psychiatric practice. As a good psychiatrist, we'll expect you not just to treat your individual patient, but we'll also expect you to be responsible for the care of the communities that you practice in. And I'm sure that good medical practice will follow. General Medical Council will follow, I'm sure. And I urge the Indian Psychiatric Society to also consider this as to what would be the role of a good psychiatrist in terms of the management, not just the individual patient, but of the community. And I think signaling from the top, I think is quite important. I'm proud that the college is taking a lead on that. And why is that important? I mean, that an illustration of this is, the farmer suicides. I know it's a political hot potato and then people don't talk about it. And then there are differing views, and we've had presentations. I've attended lots of talks about this, and then differing views exist, right? But I think you need to ask the question that, are we going to be able to fix farmer suicides by only prescribing antidepressants or ECTs? Or does it require a wider response? And if it requires a wider response, then I think we need to ask the question that, can the training of psychiatrists be sustained by only having a conference where you largely see drugs being talked about and stalls where we are only specifically mainly talking about medications rather than also talking about psychosocial treatment factors and indeed causation. So I think that requires a significant but subtle but significant shift in the training of psychiatrists, where they start thinking of themselves as being responsible for influencing the wider psychosocial determinants of health. And then clearly, when you start thinking in terms that debt, poverty plays a significant role in the suicide of vulnerable sections across the world. So farmers' suicide in India is an example, but the same factors operate in suicides across the world. And I think when you think that as psychiatrists, we would like to imagine that we are the people who are interested in stopping those suicides, then I think we need to understand, how does poverty actually interact with factors, maybe genetic factors, interact with biological factors to actually increase your risk of suicide. Now, where are those epigenetic studies? And I think I'm going to touch upon that has been lacking in our training program. And so the last point, which I think is a significant challenge, is around regulation. I know this program is a bit old now, but I think caused a lot of controversy in India. And I think, in across the world, I think when regulators step in and try and control doctors and doctors' practice, it creates problems. And we've seen workplace violence against doctors in India, which has been challenging, particularly for psychiatrists. But I think the way to address that will be to try and reestablish trust between doctors and patients. So that's a summary slide, which kind of covers all the challenges that I've talked about. And I think really the main focus for me, I think, is in terms of challenging ourselves as to how we can address inequalities, but also recognizing the psychosocial factors are quite important. How do we work with communities rather than just on individuals? And how do we reestablish that trust between doctors and patients? So I'm going to try and focus on some of the innovations now. And I think the first one, I think, has to be personalized care or precision medicine. I think, hopefully most of us are in medicine because we want to practice personalized care. We want to tailor our treatments and our assessment to the individual. And then so what helps there? And I think if you look at how the science of proteomics and metabolomics has advanced, we know that the range of markers is increasing, but our understanding of, well, what is the genetics of all the protein output of a genome in a particular cell, and how is that influenced by the environmental factors, I think is still very poor. So I think though we know that, so there's a lack of specificity in understanding this. And then the classic example is in genetic studies. So we've isolated maybe thousands of genes now, which have, through association studies. So we know, I used to be involved myself in looking at depression. So we know that there are several thousand genes that are associated in increasing the risk by maybe 0.5%, 1% of depression, of schizophrenia. Interestingly, none of the genes are specific. You find that they often tend to increase the risk to a range of different disorders. Also, a lot of these genes expression of these genes is very much contingent on the environment. And I really feel that we just haven't seen the epigenetic studies that would inform and improve our understanding. So if you look at the classic study of poor urban housing and the risk of schizophrenia, now every psychiatry trainee is taught that. We all know, and you can answer an MCQ question about that. Well, what does it mean when a patient comes to you and they're living in poor urban housing? What does it mean? Which people who are particularly vulnerable? Who is less vulnerable? And I don't think that in the last 40 years that we've known this finding, we've been able to answer that question. And we should be challenging that. We should be asking for funding to answer questions like that. How do we improve the specificity between our understanding of genes that we know are involved and the environmental factors that we know are involved? And I don't think that we've really been able to answer those questions. The same thing with environmental principles. Again, we've talked about life events, and nothing, there are legions of studies that link life events and increase risk to depression, increase risk to schizophrenia, increase risk to bipolar disorder. Again, host of non-specific findings. What we don't know is that are there particular life events that intersect with particular genetic genomes to actually enhance or amplify the risk. And I feel that's where we want us to go. And if we don't go there, I think we will find that we'll be left behind, because if you look at where is the advance in precision medicine coming, it's not from psychiatry, which would have been the natural leader, because we've been doing this for the last 7 decades. It's coming from oncology and endocrinology and respiratory medicine, where they are targeting, either individualized environmental treatments or individualized biological treatments. And I feel that understanding that interaction between environmental and genetic factors is absolutely important. So this is a paper that was in the BMJ recently that talked about that if you are a GP and if you've got 10 minutes with your patients, then do you give them, and the patient presents with hypertension and you want to reduce the risk of death by cardiovascular illness, what do you do in those 10 minutes? Do you prescribe them a statin, which has a number NNT of 300? So you'll have to treat about 300 patients to save 1 life, or do you prescribe them lifestyle medicine, things like weight management, smoking cessation, etc.? And I think that is a valid question. What would you want as a patient? Would you want something that actually has a much better chance than 1 in 300? Or would you want a tablet that it can be given in 2 minutes, taken in 2 minutes, and has a chance of 1 in 300? I know what I would want. I would definitely want something that has a much better chance than 1 in 300. And so I feel that though we are the natural leaders in personalized medicine, I don't think we've capitalized on it. And I don't think we've talked about it. And I think, in fact, you find that psychiatry and psychiatrists, I think, tend to lurch to the biomedical model, thinking that if we talk more about drugs, if we talk more about genes, we will actually somehow be real doctors. And I think rather than thinking about it, if we actually investigate the real links between the complex world that is the psychobiosocial world and try and understand that, then we will actually be leaders in not just psychiatry, but leaders in the whole of medicine and science, in fact. But I think these are exciting questions for science to answer. And so that's where our thrust is as a college. I think we've been working on this. This is a report that I've written with some of my co-authors on person-centered care. What are the implications for training in psychiatry? How do we actually improve the standards of training in psychiatry in this? And I think we'll be now rolling this out across our MR Psych programs across the country, and of course for our international trainees as well, who will be doing their exams on the new curricula. And I'll talk about that in a second. But also, I think going back to things that we know around formulation is quite important. And this is really important because it produces not only better outcomes for patients, actually is more cost effective. Again, umpteen data to show that the reduced hospitalization rates and the number of days that people spend in hospital, etc., reduces significantly with better holistic, whole person biopsychosocial care. And so our new curricula are very much focused on that personalizing ethos, and it's very much focused on the ethos of public mental health as well. So these are our 2 big pillars. And as part of that personalizing ethos, we have a host of patient educators, and I think this is what we'll be rolling out. So I've been doing this at my medical school for the last 15 years. We've expanded the program significantly. We are probably the world's largest program with more than 50 patients involved directly in teaching our medical students. And we employ 5 of them as faculty members. And as patient educators, are involved in the design, delivery, and assessing our students. And of all the teaching that the students get across the whole of medical school, this is the one element that gets the best feedback. And so you can see that why is it important to actually involve patients directly in teaching the lessons around personalizing care and precision medicine. So over to public mental health. Some of you may be aware of Tom Insel, who used to run the National Institute of Health, which is the biggest research organization in the world, budgets of billions of dollars a year, more than $50 billion worth of research funding. And this is what he had to say. He acknowledged that in all his years at NIH, 20 billion spent on research, lots of papers, but what was there to show in actual terms of outcomes? What did you save any years of patient life? Did we improve the quality of life of how many patients? And I feel that that is the challenge that we have not challenged our academic researchers with, or our academic educators with. And I really feel that we need to be challenging our academic researchers and academic educators to say, how is your output going to actually improve the life of your patient on a daily basis. And so that's where we are going as a college. We are committed to doing that and incorporating that not just in our curriculum, but in everything we do. So this is our new curriculum. And you can see that this is one of our higher level outcomes. We only have 9 higher level outcomes, but one of the higher level outcomes is very much about health promotion and prevention in community settings. So this whole public mental health agenda is very much a part of that. And what sits underneath that higher level outcome are things like this, that we expect our trainees and psychiatrists of the future and our current psychiatrists, to be honest, to understand and recognize and address systemic and structural inequalities. So we need them to be able to do that and understand how that influences outcomes for patients at all ages, and also how it impacts on their working relationship with colleagues. So for us to say that I can't do this because I can't influence social care is, in my opinion, as a dean of the Royal College of Psychiatrists, not a good enough excuse. You need to know how to influence colleagues to make things happen. And that should be part of your training. And that is what will happen in our new curricula. So that is an important element because we have to think of the whole systems approach. And so not only just understanding the social determinants of health, but also understanding the impact of that on the presentations that people have, understanding that patients present to you will often be having that inherent power imbalance. And so how do you use your power justly, judiciously, and fairly? And how do you maintain that awareness of that power that you have as clinicians? Understanding of how there is gender imbalance, how there are ethnic disparities in presentation, and how that impacts on outcomes. So all of these factors are very much a part of our curricula. And to illustrate that, we've started a new initiative. I've started this Dean's Grand Round. So over the next year, you will see around 8 webinars. Please log on to our website. Some of them may be free, but others will be for members only. Essentially, the main aim here is to how do we narrow the gap between evidence and practice? Now, we know that the gap is usually anything within 15 to 20 years. So umpteen number of journals, articles, and research studies have shown that the gap between what is known to be evidence, accepted as evidence, and what actually happens on the ground level at practice is 15 to 20 years. So for 15 to 20 years, our patients are suffering. I'm very committed that our education will have to work harder at narrowing this gap. And so our grand rounds will start with a clinical topic, illustrating the gap, but we'll have 4 key elements. So the first will be the lived experience, a real story of an individual patient or a community organization that will talk about how has the gap actually affected their outcome. But then also present the academic evidence. And third, crucially, the communities aspect I talked about. How is it actually impacting on the community, the wider community? And then what data do we have to understand what is the impact on the wider community? And finally, how do we actually equip our trainees to start making a dent in that gap? So talking about just knowing that a gap exists, that my patients are dying 20 years younger is not good enough. Knowing why it's happening. So I've done an ECG, that's not good enough. How have I narrowed the gap? I think that's what we want to see. And what have I done to actually start narrowing the gap? What have I done as a trainee? How have I set up a clinic system where I'm making sure that all of my patients are getting those physical tests done? Do I know whether all of my patients are getting physical examinations? Do I know whether my patients are taking the treatment that they've been offered, etc.? So I think you can see that the bar is being raised higher. We want our trainees to think that, well, they have to actually improve the quality of care they provide during training. It's not something that you just learn towards becoming a psychiatrist. And so in conjunction, we've just launched our Public Mental Health Implementation Center at the college. It was inaugurated by the Parliament in the Parliament just last week. And we'll be working closely with this implementation center to put some of these in practice. My third priority, I think, is about digital literacy. I think, we've all been through COVID. Ananta, you spoke about COVID and the impact of it. And one of the perhaps unintended outcomes was that telemedicine just came like a big storm. Now, the New York Times ran this story to say that 10 years of change in 1 week, which was true, because suddenly you can see the number of Teams meetings just went up dramatically. And we had to write this article very quickly for our trainees to say that, well, how do you actually conduct remote consultations? But the change, 2 things. One is that this was already happening in large parts of the world. I used to go and teach in a part of the UK, which is remote islands, 15 years ago, and they were all set up for remote consultations 15 years ago. It was happening, that was routine practice then. And I should teach people remotely then, using some of these programs. So this wasn't new. And I think, in Australia, in Canada, this has been happening for some time. And technology is not just about remote consultations. Technology is far more than that. And as practitioners in the 21st century, we all need to be able to use this and leverage it to improve the quality of care for our patients. And I'm really committed to make that happen. And so we know that, things like, if you just look at the simple depression pathway, now you see a patient and you might think that, okay, I've prescribed them sertraline, they didn't respond to sertraline, I've now given them venlafaxine, that's great, the patient's got better. But remember that that patient has come to you, but a chunk of patients have not even come to you, right? So they've fallen out of the care pathway at the very first stage because they didn't even seek help. And then if you look at others, there will be people who will not respond to drug 1, drug 2, CBT or therapy 1, therapy 2. And so at every stage, there will be some attrition. And I feel that we are good at managing people who actually come to us in our clinic. We are very bad, I would say, at managing the overall care of the people who need to be in that pathway. And that pathway management, that ownership of that pathway doesn't belong with us. So I think we think of all the patients who sit in your clinic, or who's going to have that oversight of the entire population. And that training is lacking and that oversight is lacking. So technology can help here. I think better understanding, we even have AI and machine learning tools that can help in processes like risk assessment, who is accessing care, who's not accessing care, all of these things, personalizing treatment, how can we track outcomes, how can we predict relapse earlier? All of these things can be helped with technology. And I want to make sure that trainees of the future and current trainees, current workforce are equipped with this. So I've launched a workforce, task and finish workforce that is looking at this. And within a year, we'll be making specific recommendations about how do we ensure that our digital literacy of all our trainees is the best in the world. We are launching this in conjunction with the WPA, Virtual Learning in Psychiatry, a guide for educators that covers some of these topics. I know that this is a big issue for India because, India's got the National Digital Health Mission. And I think that's a great opportunity for India, I think, to actually deliver some of the sustainable development goals. And what I would ideally like to see myself, having trained in India, is to see how this digital health mission helps us deliver the sustainable mental health goals for the population. So going to the last bit, I think I just want to talk about my role as medical educator. So we're doing the virtual learning, and I think there are many things. I don't want to spend too much time on this because this is a little bit technical, but I think what has happened in the last post-COVID period is there's been an absolute explosion in virtual learning. Everybody's doing remote learning. We need to be a little bit careful. We need to take one step back and recognize what can be done virtually and then what can't be done virtually. And I think here's my very technical test. It's called the laundry test, that if you think that you can fold your laundry and do other stuff while engaging in an experience, then you probably don't need to do it face to face. Then maybe that's something that can be done asynchronously. So you can then have a webinar and then follow it up. But there will be times when you really want to engage with students directly, more workshopy kind of elements. And I think if a trainer is giving up that time, then you want to make sure that you utilize that time in the best possible way. And that's why you have almost a flipped classroom model where people study and come, and that's what we are using with our medical students. But the time that we have with the trainer, then the trainer is fully available to trainees to ask questions and sort their queries, etc. And so our online learning has online quizzes. It's got the reflections. It's got lots of follow-up tasks, etc., to make it more interactive. In fact, throughout the COVID period and even now, what we've done is we've provided clinical placements virtually to many of our students. So we are running remote clinics where our students can log in remotely, but we're also running our expert patient clinics. So expert patients are our patient educators, and then we invite them to a teaching clinic. And again, that can happen remotely. So we're also exploring virtual reality. So scenarios where we need multiple people. And I think it's slightly difficult to organize that virtually. And so it's much easier to then organize a virtual reality scenario. So scenario which is happening in the emergency department, for example, a patient walks in having taken a significant overdose, and they have to be seen by a medic and a psychiatrist and a nurse. In that scenario, I think virtual reality is quite helpful. We are looking at our exams. We're doing a lot of changes to our assessment strategy. I won't go into all of that now, But one of the things that hopefully we have piloted is using digital short answer questions. And so moving away from just a single best MCQ answers, which I think has some shortcomings, to a more open-ended questioning method, which actually uses AI and so allows us to mark them digitally, but also allows the candidate to write the way they want to. So the question can be posed like an open-ended question rather than giving them fixed choices. So the principles that we apply for our patients in terms of holistic care, biopsychosocial, also apply to us. And I think one of the things that stops us from being as effective clinicians as we would like to be is that, you know, like our patients, we also are subject to illness, including mental illness. And increasingly finding that more and more of our colleagues have felt stress at work, have not been able to practice medicine. Some of them have felt that they're not cut out for medicine. So we launched a program called Dr. 1 in 4, which we've been running through the COVID period at actually bringing in doctors with lived experience of mental illness to talk about what does it feel like to come to work when you have had depression, when you had schizophrenia, when you had bipolar disorder. What does it mean to work, and what does it mean? What are the strengths that it brings? What are the problems that it brings? And that's been an extremely popular program with our medical students. And so, talking in terms of the future of psychiatry, you know, I think when we think of psychiatric training, we tend to think very narrowly. I feel we think in terms of neurosciences, we think in terms of a bit of psychology, a bit of social sciences. I think we need to think more broadly. We need to really fan out. We need to be thinking about robotics. We need to be thinking about informatics. We need to be thinking about policy and politics and economics and health policy. Now, not everybody will need to do a PhD in each of these topics, but at least a basic introduction, I think, is mandatory. And then I think hopefully some of them will try and specialize in those areas. And that's the model that we will be seeking in the UK. And so I like this quote because, well, I think Ananta and Agnes will spot that it says, the psychiatrist of tomorrow while retaining his hard-won expertise. So that is a bit of a giveaway because it's clearly 50 years old when they thought that only male doctors will become psychiatrists. But if you read the whole thing, we haven't really come that far. I think it talks about, you know, that psychiatrists will be more of a neurobiologist, will be more of an endocrinologist, will be more of a behavioral scientist, even a mathematician. And I feel that all of these expectations have not been realized. And I think it's time for us as psychiatric trainers, psychiatric educators to really address this. And certainly, I think that's where we are going as a college. So for me, I think as a college, all of our courses will really be addressed at addressing the skill gap. Where are the gaps in the skills? Where are the gaps in delivering that gap between evidence and practice? How do we deliver that? So this is where we are going. So every effort that we do will be in the interest of our patients. And so we are moving from we should to I will, and we've started working on that. Do log into our page on the college website, have a look at what we're doing. And if you want to participate in our quiz, you can participate by submitting a question. And so my details are there, but there's also an email address for the quiz question as well. And I'll stop there. Thank you.
Thank you, Subodh, for the nice and excellent deliberation of a topic which is actually really thought-provoking. What best we can do, and psychiatry is as a leadership role. We are thinking for long since, and it has been discussed in so many places. And what role exactly you can play, we are still looking up to it. And if you go to the role-playing model as a leadership, that we still the one of the concept of Indian medical graduate, you have to play a role. So it has to from the basics, from the undergraduate level. And if you learn that at some extent, and I think by the time you reach to your level of post-graduation, it will be helpful to you to some extent. It's a really nice experience, and we can go ahead. So I'll sir, for your comments.
If there are any questions, please go ahead and ask him. She's there. Please.
I think we could do with still, along with trauma, we could still do with a greater focus on understanding child development, the link between child and family mental health and child and adult mental health, and more joined up working. So I think it's an excellent start. And for me, this is the first time that the Royal College has actually brought together the link between education and practice, the focus on inequalities, and the understanding of the various early factors. So that's really very much
Thank you.
welcomed.
Is there anyone who has some query in mind? Okay, अच्छा. On कुछ है chat box में? If permitted by the chairperson, I'll have one or two small queries. One is, one of the slides mentioned the violence in hospitals in Indian. There was a survey, there was a paper on that. Such things, such violent relatives, they do not occur in UK or USA. Such scenes don't occur.
No, I think I think the point I was making was that there's breakdown a bit of trust between patients and doctors. So if you log on to Twitter or any other, there are almost wars happening. I think there are battles happening between professionals and patient groups and carer groups. And I think that's because people feel that doctors don't understand the patient perspective. They don't understand carers' perspective. Doctors feel that carers and patients don't understand their perspective. And I really feel that how do we bridge that gap should be a part of our training.
Correct.
It can't be okay for us to say that, well, they should understand. I think we are the professionals. We are being trained to do a job. Lay people are not, So I think how do we actually manage that gap is something for us to learn how to do that. And I think that does mean, I feel that, I think this is the reason why I've been involved in changing our curriculum. Our curriculum talked about psychoeducation. It was around, we will teach our patients, we will teach our carers. We've changed the language. We said that we will teach, but we also learn from our patients and carers. And I think we have a lot to learn from our patients and carers, right? Because every story is individual, right? And their experience is unique. So if somebody comes in and say that, look, you gave me this haloperidol injection, it's causing lots of problems to me. I think it's their experience. I think we have to listen to that, right? And then we do, right? We have some, we understand side effects. Now, if they come in and say that, look, this has started causing, my voices have increased, then we'll say, well, that doesn't cause that particular side effect. I don't know, what are you talking about? But that dismissing is because it doesn't sit into our model. We still have to listen to them and then work with them. And I think that how do we train our doctors so that we don't operate in a pigeonhole fashion, I think is important. And that's where our model of getting patients involved in teaching medical students has been very successful, because our patients then tell doctors, and then doctors get realized. So when I teach about schizophrenia, I am talking about, the dopamine hypothesis, and I'm talking about the neurobiology of the frontal lobe and all of that stuff. And I've got a patient with me who's experienced schizophrenia, who's talking about what does it mean for them. And then my students are able to ask questions which they generally don't get taught about. So they will say that, like, so the fact that you get all these hallucinations, how does your wife respond to that? What does she think about that you are getting all these voices? What does she say? So things like that, how is it impacting on your relationship with your neighbors? Those kind of things come up because they are having a direct conversation with the patient as well. And when I'm talking about medication, the patient can tell us what is the medication impacting them. And I feel that is an important move, that we have to incorporate more direct learning from patients and carers in our education. I think that would be a big change.
Just as you have included this doctor-patient communication and all these things in your curriculum, there's the first welcome step in our country, especially in state of Maharashtra, that they want to teach the doctor-patient communication skill, doctor-patient relationship right from the first year of the medical school.
Very good.
Yeah, National Medical Commission.
Very good, very good.
So it's a good and welcome step. The other question is, in Western countries, there may not be violence in your clinic or hospital, but every doctor feels that every patient is a potential litigant. He may not come and hit me, but he may sue me for $50,000. So it's almost like this.
I think it's the same thing. I think that again the litigation comes from the lack of trust, and I think again studies have shown that when there has been a better understanding, and when in fact it's been the other way around. Often patients don't complain about doctors whose communication skills have been good, even when there has been a actual negligent care. So the communication skills are important, but I don't want to say that communication skills are important only to manage that trust. I think it's actually important to improve the outcome for patients as well.
Correct.
And I think that is the important thing. So not only is the therapeutic relationship building, we know in psychiatry is critical in improving outcomes. And so, I think how do you use your therapeutic relationship building in improving the outcomes that you will achieve by giving a patient a depot medication is something that we should be teaching. Now, I think some clinicians are skilled, they do that automatically. I don't think that we ensure that every trainee does that and every psychiatrist does that. And I think good systems should make sure that everyone is able to do that. So even if you're prescribing ECT or haloperidol or whatever you're prescribing, how do you then use your therapeutic relationship building skills to enhance the outcome? How do you personalize the treatment to that individual? I think is key. And that's where taking that broader context is important.
That is the bottom line, building up the trust.
Absolutely.
And doctor-patient communication skill and improving that. I think that is the bottom line. Thank you.
Thank you so much.
Thank you, Subodh. If there is no question, we really welcome your way, and I think it will be more of an interactive session. A lot of things to learn and a lot of things to initiate. Thank you, Anta, for joining. And really, child resilience is a very important aspect in the mental health and afterwards. So that is a very important aspect. Thank you. Hand over to the.
Yeah. I would like to ask the chairperson to felicitate Dr. Subodh Dave, both the chairpersons. I would like to ask Dr. Subodh Dave to felicitate our chairperson also.
Okay. Yes.
Because you're like.
That's great.
No, no, sir. You all can click a photo. No, come. Thank you. Thank you so much.